Good morning, everybody, and welcome to the second day of the INTERYem Infection Conference 2021. My name is Nicholas Wong, and I'm an infectious diseases consultant based at the Leicester Royal Infirmary in the UK. I hope you guys can hear me all right, and thank you everyone who's already signed up so far. So my relationship to INTERYem is as an invited chairperson for today's session. And I'd like to remind everyone, the conference is being held on Zoom and can be accessed via YouTube as well. If you want to search for us, just type INTERYem into YouTube and you'll find the channel. Our first speaker today is Mr. Peter Hoffman from Public Health England. So welcome to him, and he'll be starting shortly. But I thought I'd run through briefly about why the INTERYem Infection Conference is important and relevant, and put down some housekeeping rules before we get started with today's program. So just as a quick reminder, subtitles or closed captioning can be viewed on your screens just to help make life a little bit easier. And just as a brief overview of INTERYem, well, why are we doing this? Why are we hosting this conference? Well, Yemen remains the poorest country in the Middle East. The levels of unemployment and illiteracy of Yemen are the highest in the Middle East and amongst the worst in the world. After almost a decade of internal conflict, millions of Yemeni people have been forced to flee their homes and seek refuge internally or abroad. Half the population are unable to meet their food needs, 3/4 don't have safe water, and over 80% need some type of humanitarian assistance, with marked increases in severe acute malnutrition and limited availability of vaccines confounding the situation. The health infrastructure in Yemen has been decimated, and future recruitment of healthcare professionals has become even more precarious. Communicable diseases remain one of the main causes of mortality in Yemen. In addition to the worst outbreak of cholera in history, other communicable diseases, including diphtheria and measles, have increased in a fragmented state. The weakness of public health surveillance has led to difficulties in identifying and prioritizing many public health issues facing Yemen today, such as communicable diseases, including cholera and diphtheria. Lack of vector control programs has also led to an increase in diseases like dengue and malaria. Furthermore, endemic disease eradication programs, such as leishmaniasis and schistosomiasis, are not being implemented. Respiratory tract infections and diarrheal diseases remain the biggest cause of mortality in Yemen, the former now being worsened further by COVID-19. Antimicrobial resistance has gained further traction due to easy availability of antibiotics, exacerbated by the lack of doctors who may be vigilant regarding their prescribing. The effects of the shattered economy and conflict have also been felt on immunization programs. Training and continued clinical education in infection is vital for Yemen's present and future aspirations of reducing harm from communicable diseases. So this is where INTERYem comes in, or the International Network for Training, Education and Research for Yemen. We have training, education and research as its three founding motivations. We know that Yemen's healthcare professionals are dedicated and knowledgeable, but may be lacking opportunities to develop in areas that are needed to improve patient outcomes. We believe the future of health in Yemen's population resides in the capacity of its healthcare professionals, and more prominent, the need for capacity building in a particular specialty to improve patient outcomes, the higher it ought to be as a priority for training, hence the need to prioritize infection. INTERYem does not want to and cannot replace the training of infection professionals in Yemen, but we rather hope to identify gaps in expertise and training, and then try and fill those gaps by exchanging ideas, sharing expertise, and building friendships with partners from other countries. The identification and gaps in expertise and training needed by colleagues in Yemen is very much demand-driven. Training courses must be recognized as being required for the improvement of patient outcomes. The development of training courses in infection should involve all stakeholders, including ministries of health and education, medical schools, universities, hospitals, students, trainees, and patients, so that a comprehensive understanding of the objectives for training can be met and delivered. However, these courses need to be resource efficient and realistic in their ambitions, and to ensure quality, the courses should be developed using appropriate training models and accreditation from external bodies. A key aspect of our infection training is disseminating the knowledge and skills developed by the participants, so our audience today, to other infection colleagues within Yemen who can't attend the courses. So our main objectives, first and foremost, the desire to provide an update for infection specialists or an overview for those new to the area. COVID-19 will be a priority for many of you in Yemen, and rightly so, although our focus isn't exclusively on that. Furthermore, the conference will provide an opportunity to exchange information by practitioners and academics in an infection forum from several countries, and this will allow us to start collaborating. Finally, this conference will allow for the initiation of considering where the gaps in training may be and help us to start thinking about how to fill those gaps. So, just a few basic housekeeping rules before we introduce our first speaker. Please ensure that your microphones are muted and that your cameras are switched off. Most of the major speeches will be around 45 minutes long, with up to 15 minutes for questions and answers afterwards. The poster and project presentations we have to look forward to later today will be about 20 minutes each, with between 5 and 10 minutes for Q&A afterwards. Please use the chat function on Zoom to ask your questions when ready. For those of you who've registered for certificates for participating, there'll be an online link for a feedback form. Please fill this out and tell us what you enjoyed and what we could do better before we give you a certificate. As with any conference, there'll be several sessions running today, some of which will be more relevant to you than others, depending on your area of expertise. Identify which areas you'd like to attend, but bear in mind, for an attendance certificate, you will need to attend 75% of the sessions over the next 2 days. So I think that's everything from my point getting started now. So I'd like to introduce our first speaker, Mr. Peter Hoffman from Public Health England. Mr. Hoffman is a big name in the world of infection control and is a consultant clinical scientist with our public health agencies here, and has particular interest and expertise in decontaminating medical devices and the role of the healthcare environment in infection transmission. He is also a specialist editor on the Journal for Hospital Infection, and today he's going to be speaking to us about the principles of investigating infection transmission in healthcare settings. So without further ado, Mr. Hoffman.
Thank you, Nick. Okay. Can I start, first of all, by where I'm coming from? So thank you a lot for inviting me to speak on this occasion. Can I start by telling you where I'm coming from and my view on what I'm about to tell you? So I have a fairly poorly defined job function, which suits me quite well. Part of it is education. This is what I'm doing now. Part of it is taking part in issuing guidance, both guidance for professional bodies such as the Healthcare Infection Society. I recommend you look at their website, www.his.org.uk. It has of good guidance within it. Some of it is the organisation I work for, Public Health England, and some of it is national. So that's looking at the ideal. You always write guidance with the ideal in mind. But I also help colleagues on the healthcare frontline with looking at problems of infection transmission within their hospitals. So here I just act as a fresh pair of eyes on their situation. I look at what's happening there in the context of what I see in other healthcare establishments, but it's never going to be an accurate thing to do. I'm trying to establish something that happened at a microscopic level at an unknown time in the past. So all you can really do in situations like that is to look for likely routes of transmission. So that's what I'm going to be covering here. Let me start by looking at an overview of the situation from a microbiological environmental point of view. Hospitals form a different microbiological niche from outside hospitals. As Nick was saying in his introduction, antibiotic resistance is prime importance. If a bacterium is not antibiotic resistant, it's not going to compete in the healthcare environment. So it's got to be antibiotic resistance. It's got to be good at going from one environmental niche, and that's normally a patient, to another environmental niche. So it's got to be good at transferring. And once it arrives at a suitable environmental niche, it's got to be good at replicating. So either exploiting an environmental reservoir or infecting or colonizing. Now, for very good reasons of expert patient care, hospitals take people with similar susceptibilities and cohort them together in the same confined space. So things like ITUs, full of people with similar susceptibilities like tracheostomies, burns units, patients who all have similar susceptibilities and will also disperse profusely. So hospitals form a distinct environmental niche. The microbes that you will get in hospitals will be different from the microbes that we get outside hospitals. As I alluded to in my introduction, there's not a lot of good evidence here. If there's an outbreak of infection or a suspected outbreak intervention, people don't just introduce a single intervention. They introduce multiple interventions. So this is not a situation of well-controlled single interventions. But it's probable there'll be more interventions than the team is actually aware of, because not only will they introduce interventions, but people working in that environment will start to conform to what they should be doing better. So washing hands better, cleaning equipment better, changing gloves better. So there are multiple interventions, and it's never clear what single intervention, what made what contribution, or what combination of interventions acted synergistically, acted together. The other problem is that the infection transmission rate is not going to be constant. It's a shifting environment. So infections come, infections go. If the infections have gone, was it something you did? Or did they just go? Were they displaced by another less virulent microbe? There are often going to be multiple routes of transmission. So if you find a route of transmission, you haven't necessarily found the route of transmission. So you can block one of many routes of transmission. It doesn't mean you've solved the problem. The last problem in trying to establish the evidence is there's going to be publication bias. Let's suppose that 10 hospitals all try the same intervention. It works in hospital 1. It doesn't work in hospitals 2 to 10. Which of the hospitals is going to publish their results? It's going to be hospital 1. So people tend not to publish failures. Let's take a look at the nature of the problem. So we're thinking of infection transmission in healthcare. This could manifest in 2 prime ways. You could get what I think of as a classic outbreak. So high numbers of patients infected in a short period of time. This is very noticeable, but it could be more subtle than that. You could have a microbe that is good at traveling from patient to patient, but hardly ever causes infection. So you would get maybe 1 patient this week, 2 patients next week, no patients the following week, 1 patient the week after. It's not going to be an explosive outbreak that is highly observable. There may also, and I'm going to deal with this in greater detail later, be a situation where there's some sort of defect in procedure, either constant or intermittent, that allows transmission not of the same microbe, which is very observable, but of different microbes, depending on what the challenge to the equipment decontamination process was at that particular time. Now, this is going to be difficult. How do you identify there's a problem? The problems could arise in so many different ways. So for the classic outbreak, so for transmission of the same, exactly the same microbe in healthcare environments with a lot of money and a lot of technology, it would be by fine typing of microbes. In the UK, we're starting to do quite a lot of whole genome sequencing, but I don't think you need to do that in order to have a good level of suspicion that you have an outbreak. So with a certain amount of laboratory support, it would really be by traditional laboratory microbiology bench methods, looking at the same organism, the same species, the same colonial morphology, and critically the same antibiogram. This is going to give you 95% of the evidence that either you do or you do not have a classical outbreak. Without laboratory support, it's really just got to be clinical suspicion. And this is where the skill and experience of the medical practitioner is vital. So that will be for situations where there's a common route of transmission. If there's a situation where there's a route of transmission that is used by different microbes, then that's just really got to be a suspicion of increased levels of infection. But the problem here is that if there's a long-standing defect, then what you're going to be observing is going to be your normality. So even in that situation, it could be useful to look at underlying transmission mechanisms and see whether any of those exist. So it could be that your malady includes infection transmission that could be prevented. So there is always going to be benefit from going to various hospital departments and actually looking what's going on and looking for defects and persuading them to improve procedure. It could well be that there is an easy to ascertain source, such as some contaminated skin disinfectant that's being applied to patients. That's a very simple transmission, single step and easy to solve. Replace the contaminated skin disinfectant or whatever the source is. But it's probable that there are going to be multiple sources and multiple routes of transmission. If you've got, say, a ward of 30 patients and 10 are colonized with organism X, that's 10 sources of that's 10 sources of transmission. So it could be transmitted from obviously infected patients, or it could be transmitted from silently colonized patients. There's going to be transmission via staff hands. Now, people focus a lot on hand hygiene. That's probably the principal source of attention for infection prevention and control. But now gloves are being very commonly worn for a lot of patient contact, and there just is not the same attention to glove hygiene as there is to hand hygiene. Gloves are every bit as important. So there's the concept of PPE, personal protective equipment. Gloves are PPE. They protect the person wearing them. But we should also focus on PPE as patient protective equipment. So glove hygiene should be just the same as hand hygiene. In addition to this, there's going to be transmission via transiently contaminated equipment. My clinical microbiology colleagues come under a great deal of pressure if there is a suspicion of infection transmission to do microbiological sampling. This is not always helpful. So if there's a single source, such as this pot of contaminated disinfectant, yes, that might help you. If there's multiple sources, you might find one and everybody's attention will be focused on that, but you won't find all the others. Surfaces can be important without being colonized. Dry surfaces are not going to be colonized, they're going to be contaminated. So think of something like a door push plate, something people use to open a door. If a contaminated hand makes contact with that, contamination is going to be deposited on the upper contours of a textured surface. It's going to be readily available for transmission to the next hand that touches it. So probably about 80% of the contamination is going to be transferred from contact 1 to contact 2. 80% of what remains is going to be left for transfer to contact 3, and so on. So that contamination is likely to diminish rapidly. So if it was contaminated at, let's suppose, 9 o'clock in the morning, if you come along and sample it at 3 o'clock in the afternoon, you're not going to find any of that contamination because it's all going to have been removed by contact, but it's still an important surface. The other point is that contamination is not going to be evenly distributed. So I'll talk in a while about infant incubators. They are complex, multi-surface pieces of equipment. You can't hope to sample all of it. So just because you sample one area, it doesn't mean there isn't contamination, and you show it to be clear. It doesn't mean to say that there isn't going to be contamination in another area. So microbial sampling is of limited information value. Do not feel pressured into doing microbiological sampling. It can focus people onto the wrong things, and it can exonerate, it can say that bits of equipment are not important when in fact they are. So what I'm going to be doing in the rest of the talk is giving you a general approach to controlling infection transmission in healthcare. There is no standard approach. There is no one approach to outbreak investigation that can fit all situations. It's going to be flexible. It's going to be infinitely variable. And this is where you need to develop your skills. I'm going to start with one of the most difficult bits of commonly used equipment to decontaminate. That is flexible endoscopes. These have been responsible for significant transmission of infection in the past. This is a list of some of the bits of equipment that have been associated with transmission via flexible endoscopes, but there's a lot more. Typically transmission via flexible endoscopy would not be noticed as such. It's only on a few occasions where people have studied it in detail, or there have been particularly spectacular outbreaks that people have noticed. So this is the basic problem. This is I think it's a colonoscope. They are delicate. They won't stand at high temperatures, and they won't withstand a lot of chemicals. So you've got to the one thing you do when you reprocess, the one thing that you must be careful of when you reprocess an endoscope is not to damage it. It's not just the easily accessible outside that needs to be decontaminated. but there will be narrow lumens running the length of the endoscope from the tip right through to the end that joins up with the electronic stack that needs to be decontaminated, that it's vital to decontaminate. And they are incredibly expensive bits of equipment. So this is the inside of an endoscope. So in red is what's referred to as the working channel. This acts both as a suction channel, removing highly contaminated body fluid, and also as a working channel to introduce accessories such as biopsy forceps. This is going to be the main challenge to decontamination, but there are other channels that are also important. There's an air channel where air goes into the body cavity that the endoscope is in. Although this is designed for air passage from the endoscope into the patient, changes in pressure in the body cavity that the endoscope is in can force fluid back in, can force body fluid back into the air channel. Similarly, there's a water channel which joins with the air channel, which is used to clean the lens, and that too can get contaminated. So there's probably, in a colonoscope, there's probably more than 3 meters of channel with a lumen as small as a 1 millimeter internal diameter that needs to be decontaminated. So to take you through steps in endoscope decontamination, when the endoscope comes out of the patient, then within 10 minutes, there's got to be a fairly coarse clean, just wiping contamination off the outside and drawing water. It doesn't have to be a sophisticated detergent, drawing water through the suction biopsy channel. If this isn't done, it's going to compromise all later decontamination processes because patient body fluid will have dried onto the surfaces, and it really makes future decontamination impossible. This is a vital step. It should be the responsibility of the person who's using the endoscope. They might not do it, but they've got to ensure that it occurs. Endoscopes are very delicate. They have delicate outer and inner surfaces, and they can develop holes. If there's a hole in the endoscope, it means that patient body fluid can enter internal areas of an endoscope. There are 2 problems here. If there's patient fluid in internal bits of the endoscope, it's not going to be removed by cleaning, and it's not going to be removed by disinfection. But when that endoscope goes into the next patient, changes in internal pressure of the endoscope can squirt that body fluid out into the next patient. So the next patient will get whatever blood-borne virus the first patient has. There's also a risk to the working of the endoscope. The internal components of an endoscope are not going to be resistant to water-based corrosion. So if fluid gets into the endoscope, it can result in corrosion, which can compromise the function of the endoscope. It can eventually ruin the endoscope, so it's just not workable and not worth repairing. The sooner that damage is identified and rectified, the sooner, the lower the level of damage and the more feasible and the less expensive the repair is going to be. The leak test is very simple and shouldn't be an procedure. There will be a valve on the endoscope whereby a small amount of air can be passed into the internal body of the endoscope. The whole of the endoscope is put under water, and you just look for bubbles rising. If you see bubbles rising, don't attempt any further decontamination. The endoscope needs to be repaired. Then comes the cleaning step. The suction and biopsy channel is the only channel that's acceptable to mechanical cleaning with a brush. So first of all, the valves, which will probably be reusable and need to be cleaned and decontaminated separately, and the biopsy port caps, which are probably going to be single use, though if they haven't been pierced, they can be decontaminated and reused, should be removed. The outside of the endoscope should be, the whole of the endoscope should be immersed in a detergent solution. If it's immersed in detergent solution, it gets good cleaning, and it also minimizes splashes, which might put the person cleaning it at risk. Brushes appropriate for the diameter of the biopsy and suction channel should be passed back and forwards through the whole length of the suction biopsy channel until the brush appears to be clean. Then all of the lumens have to be flushed with detergent. Now, apologies about the quality of this diagram. It was like that in the original. So this shows you a device for irrigating endoscopes. So one end goes into some detergent solution. It then goes to a device with valves, which is on a syringe. So the syringe plunger is pulled back, it fills full of detergent. Then the syringe plunger is depressed, the valves stop, or the valves make sure that the detergent then goes down into all of the endoscope decontaminating, all of the endoscope channels. And that's, full details are in this WHO reference. Then this will vary according to the facilities that your hospital will have. Sometimes the endoscope will go into an automated endoscope reprocessor, or it can then be manually decontaminated using the same irrigation device. But the steps, whether it's in an automated process or a manual process, should be the same. First of all, the lumens get irrigated with detergent. Then that detergent needs to be rinsed away because some of the detergents can inactivate some of the disinfectants. Then a wide spectrum non-corrosive disinfectant needs to be used. This could be glutaraldehyde, it could be chlorine dioxide, it could be peracetic acid. Those are the main disinfectants. Then it needs to be rinsed with good quality water, because that water is going to stay on the endoscope and will make contact with the next patient it's going to be used with. The endoscope, if it's not going to be used within about 6 hours, can be used without further decontamination. The problem is that the endoscope will be wet after it's been reprocessed, and this is disinfection, not sterilization. Bacteria can grow, and that might be a risk to immunocompromised patients. So either the endoscope should be used fairly rapidly after decontamination, or if the lumens are flushed with an alcohol solution, then that will preserve them long term. So either use the endoscope that same day or flush the lumens with alcohol, and that will preserve them for longer term storage. Next are ultrasound probes. Again, useful and essential bits of medical equipment. Probes that have contact with intact skin are usually a minimal risk and just need social cleaning unless the patients are highly susceptible. And here I'm really talking about burns patients and neonatal intensive care patients. Those need cleaning followed by disinfection. Then there are probes that are used inside body cavities. So body cavities, mucous membranes are permeable to a lot of viruses, impermeable to most bacteria, but not all bacteria. Ultrasound probes used inside body cavities are a higher risk than those used with intact skin. Use of a sheath or a barrier on an ultrasound probe does not remove any of the requirements for decontamination after each use. Sheaths develop holes. Sometimes sheaths are supplied which have holes, and quite often they will develop holes during use, which means that contaminated patient body fluid can contaminate the body of the probe itself. It's very difficult to remove a probe cover without contaminating the probe underneath it. By definition, the gloved hand that removes the probe cover is going to be contaminated. So it's probably going to contaminate the surface of the probe that was protected by the sheath as the sheath is removed. And there will be parts of a probe that are not going to be covered by the sheath, but will make contact with the operator's hands during use. Those are as important as the bit of the probe that actually goes into the patient. So this is one example. This is a vaginal ultrasound probe. You can see the gloved operator's hand. You can also see where the sheath ends. The gloved operator's hands covers both bits of the probe that are protected and bits of the probe that aren't. And look at just how closely that cover is fitting. I can't see how it could be removed without contaminating the probe underneath. This is probably the most substantial challenge in ultrasound probe decontamination. It's a transesophageal echocardiography probe. So these can allow visualization of a beating heart in real time. So there will be an ultrasound emitting source at the probe tip. Now, the problem here comes in that only the patient insertion tube is amenable to insertion in fluid. So the structure of these is a bit like the endoscope I showed you, but without the lumens. So in theory, they should be more accessible to decontamination. But because only the patient insertion tube is immersible, it still leaves you with problems. There are the angulation wheels here. So these angulation wheels, and on an endoscope, can turn the tip left, right, and up and down. These will be contaminated by the operator's hands. They're an intricate, poorly accessible surface, and they can't be immersed. Similarly, the plug socket, which is used to connect to the electronics, can't be immersed. So just because you can decontaminate from the probe tip to where it joins the handles by immersion, it doesn't mean that the whole device is going to be amenable to good quality decontamination. Let me share with you, this is the first time I was ever aware of TOE probes. I was in a hospital for a completely different reason and saw these things that looked like colonoscopes but weren't colonoscopes, hanging to look like gastroscopes but weren't gastroscopes, hanging up in a cupboard. If you focus in on that, this is what I found. The people at hospital were very embarrassed. They took the endoscope away, but there is clear blood contamination here. This is one of my favorite photos because what I like is the very obvious blood contamination right next to the disinfection quality assurance sticker. So presumably, TOE use can break mucous membranes. There can often be quite a lot of blood around. Presumably the operator had blood on their hands, and when it came time to disconnect the TOE probe at the end of the procedure, they contaminated the electronic socket. So this was an accident waiting to happen, and it did happen at a hospital 200 kilometers. It could have happened anywhere. Patient with known hepatitis B had a cardiac surgical procedure on the afternoon of day 1. Their strain of hepatitis B had a genetic glitch on it that made it very identifiable. Patient on the morning of day 2, cardiac procedure with TOE use, but this patient had already been immunized against hepatitis B. Patient 3 on the afternoon of that same day acquired the index patient's strain of hepatitis B and sadly died about 8 weeks later. I was part of the investigating team for this. There was a small possibility it could have been the laryngoscope used by the anaesthetist, but the overwhelming probability was that it was the TOE probe. There were multiple defects in TOE probe decontamination. So probe decontamination, this is an example of TOE probe, but it applies to all intracavity ultrasound probe decontamination. It should be applied by trained staff. You can't just give somebody some wipes and expect them to know exactly what to do. All parts of the probe, not just the patient insertion tube, need to be cleaned and then disinfected. And this has got to be after every patient use. So on the right-hand side, you can see an area of a wipe that I have highlighted in red. That was used to wipe in between the angulation wheels. So there's patient blood contamination within that surface. So it's not just the patient insertion tube that needs to be decontaminated. Here, a TOE probe is very difficult to decontaminate, far more difficult than transrectal and transvaginal ultrasound probe, just because it's so long, sort of over 3 meters in length. So hanging it up on a stand, a drip stand is ideal, is necessary. Then it can't be put back on the same surface that it was originally taken from. There's got to be a clear, dirty to clean flow. So once it's decontaminated, it's got to be put back on a surface that hasn't had an undecontaminated probe making contact with it. An abrupt change here. Multi-resistant gram-negative bacteria can live quite well in the healthcare environment, but it's got to be the wet healthcare environment. And here I'm talking about the drainage system of a hospital. So this is drainage systems will be the same in healthcare and non-healthcare environments. If you look underneath a sink, there will be some tubing like this, some pipework like this. This contains trapped water in order to stop sewer gas from coming up into the environment where that sink, shower, or bath is. Bacteria will live in there. Bacteria will live there as a biofilm. This is an important concept for the next 2 things I'm going to deal with. Bacteria like to control their environment. The only way they can do that is by sticking to their environment. They will stick to their environment with a sticky capsule. They will grow within that sticky capsule, replicate, and form a mass. That mass will be composed of lots of different microbes, bacteria, fungi, and protozoa, all competing with each other, sometimes cooperating within this gelatinous mass. Microbes, in particular the bacteria we're thinking of, will then emerge from this mass stuck onto a surface and swim free, so-called planktonic forms. Below, in the last part, in the bottom part of this slide, is a scanning electron microgram of a biofilm. There's nothing subtle about a microfilm. It's a mass, millions and millions of bacteria. What you don't see in this scanning electron micrograph, because it's been dehydrated, is the bacteria, is the capsule, the polysaccharide, the slime that this is in. But penetration of disinfectants. You can't kill biofilms with disinfectants. They will just kill the very top layer, but they won't penetrate. So you can't deal with this by pouring disinfectants down sinks. If you remove that, the biofilm will be continuous from the sink right down to the point of discharge from the hospital. So if you replace a contaminated waste trap under a sink, it will just be rapidly recolonized. The only way of approaching this is to learn to live with the problem and be assured that what is in the drainage system is on a one-way path out of the clinical environment and doesn't come back into the clinic environment. The vital control mechanism here is making sure that the water that flows from the tap or faucet does not go straight into the drain, because that will cause reflux of the drain content back out into the clinical environment. So if you've got a tap that goes straight into the drain, either replace it or bend the outlet so it hits away from the drain. Or you can install sinks with drains at the rear, so there's no chance of that happening, but that needs a lot of money. So this is an example of what happens. I was going around a burns unit with some colleagues, noticed that this water was flowing directly into the drain, was talking about this, then one of my colleagues noticed that I was being splashed. So this is reflux of water, contaminated water from the drain, hitting someone near the drain. This should not happen. If there are splashes and they're splashes of fresh water, not from the drain, that doesn't matter. It's not going to be contaminated. If it's from the drain, then it's a significant problem. Showers often get blocked up. If they get blocked up, then the person taking the shower is going to have their in a solution of bacteria that have emerged from the drain. These will probably contain highly antibiotic resistant gram-negative bacteria. The only thing you can do here is to ensure that the shower drains efficiently. So it's not just an aesthetic problem if shower doesn't drain properly, it's a hygiene problem. This is an example of a paper. This is an example of the sort of multiple approach to outbreak control. That it's impossible to say definitively that it was a problem, but the problem seems to have diminished substantially with a particular intervention. And this is ensuring good drainage from showers, sinks, and that toilets don't block up, reduce the transmission levels of a multi-drug resistant Pseudomonas aeruginosa. Neonatal intensive care. Just as there will be biofilms in drains, there can also be biofilms in taps, faucets, and these can be colonized with Pseudomonas aeruginosa. So there was an incident where babies in the neonatal unit were infected and some sadly died from Pseudomonas aeruginosa, which was from the taps in a neonatal unit. These are some of the components of the taps from that neonatal unit. There is something at the end of a tap which is called a flow straightener, which ensures that the water comes out in a cohesive form and doesn't spray too much. This has a high surface area and can get colonized with Pseudomonas aeruginosa. Pseudomonas aeruginosa is a strict aerobe and can only compete in a mixed biofilm where there's a ready supply of oxygen. So this will be at the air-water interface. This is a strainer from that tap. You can see the biofilm on it. This is a profuse biofilm, and the color of that biofilm suggests that Pseudomonas aeruginosa are colonizing it, and they could detect Pseudomonas aeruginosa in that biofilm. The quality assurance of ensuring that water from taps in a neonatal intensive care unit is not colonized with Pseudomonas aeruginosa is poor. So the best thing in a neonatal intensive care unit is to make sure that babies don't have contact with tap water. If you've got sterile water to clean the babies with, that's fine. But boiled and cooled water that is no longer than 1 day old would be a suitable alternative. Incubators. These are horrendously difficult pieces of equipment to decontaminate. There's no easy way around this. It doesn't matter so much while one baby occupies one incubator, but between baby occupancies, they should thoroughly be cleaned. All of the surfaces should be cleaned, disinfected, and then rinsed with clean water using a clean cloth between different baby occupancies. Particular attention needs to be given to baby contact areas, and that's the mattress, and staff hand contact areas. That means ports and port latches. You're probably going to have to reuse single-use items. This is common in many parts of the world where there's a restriction of supply. This can be done successfully, but it's got to be done with a certain amount of thought. So items need to be thoroughly cleaned first and then fully immersed in a disinfectant. You can see in that picture on the left where there's part of a tube that doesn't make disinfectant contact while it's being reprocessed. That's not going to be decontaminated. They then have to be thoroughly dried. So on the right is tubing hanging up on drip stands such that it can drain and dry. If it doesn't dry, it's going to be recolonized with bacteria in the liquid phase that remains. Babies start out as sterile surfaces, but sterile and microbially nutritious surfaces that are very readily accessible to contamination and colonization. And feeding bottles are a very effective way of getting bacteria into babies. So ideally, feeding bottles and express breast milk kit should be specific for one mother and one baby. They need a thorough clean, total immersion. They can't float, total immersion in dilute chlorine. It's difficult to say what the concentration of chlorine is, because in a bottle of hypochlorite, in a bottle of bleach, sodium hypochlorite, because it will vary. It tends to be around about a 1 in 500 dilution of commercially available bleach is the right concentration. 125 parts per million is a low concentration of available chlorine because you've got to allow for failures in rinsing, and the concentration of hypochlorite still has to be that won't damage the baby if that happens. Then they need to be rinsed with clean water, recently boiled water is ideal, and then air dried rapidly and stored covered. Burns are probably one of the ultimate challenges to infection prevention. Burns are always going to get colonized and then infected, first of all with the patient's resident flora, and then after that with the burns unit's resident highly antibiotic resistant microbial flora. So this is a prime example where you're cohorting patients with the same susceptibility in the same space. Mattresses in burns units have to be impermeable, so they're accessible to cleaning and then cleaned and disinfected thoroughly between patient. There's going to be very, very good contact between a burns patient and the mattress they're on. So the mattress has to be intact and amenable to cleaning. There's got to be good contact time between the disinfectant and the mattress, at least 1 minute's contact time. More is good. This is an example of a mattress that was permeable. So yes, you can clean the mattress cover, clean and disinfect the mattress cover, but then fluid is going to travel, contaminated fluid is then going to travel back up through what's under the mattress when it's in contact with the next patient. Changing burns patients' dressings is going to be a problem. It will vary according between burns units. This is one of the typical things that can be used. It's a shower trolley. So the patient is put on this shower trolley. A shower head or sterile saline is then used to wet the burns dressings, and there's a drain here for fluid to escape. These will be used for more than one patient. These need to be very thoroughly, between every use, cleaned and then disinfected. It's not just the upper surface that needs to be cleaned and disinfected, but the lower surface. This blue thing is removable. So it should be cleaned and disinfected on the upper and the lower surface. And the whole thing has to be amenable to effective decontamination. If there are cracks and fissures in the shower trolley mattress, then it can't be decontaminated effectively. There are going to be non-sterilizable items that will come into contact with patients. Things like the pulse oximeter. This is a pulse oximeter that was ready for use that I found. You can see contamination here. Pulse oximeters are difficult to decontaminate. People tend to give them a wipe on the outside, but it's the inside surface that has contact with a patient, and they will have prolonged contact with patients. Blood pressure cuffs. In outpatients and general wards, they're really not that important. In burns units, they are vitally important. It's very difficult to decontaminate a blood pressure cuff effectively. Ideally, in a burns unit, a blood pressure cuff and a pulse oximeter are allocated for individual patients for the length of their stay. Then they're thoroughly decontaminated afterwards. If you don't have the resources to do that, then they've just got to be thoroughly decontaminated between each patient contact. Bedpans and urinals. Bedpans are a very effective way of transmitting multi-resistant gram-negatives between patients. They can't be reprocessed by cleaning if they're used by multiple patients. If there's one bedpan and one urinal for one patient, then they can be reprocessed by cleaning. If they're used by multiple patients, then there has got to be cleaning followed by efficient disinfection between each use. Chemical disinfection has problems in that chemical disinfectants are going to be inactivated by organic matter. So the organic matter needs to be effectively cleaned before a chemical disinfection is used. And there's got to be total coverage of the bedpan and urinal. It needs sufficient contact time. So it will vary with disinfectants, but at least 30 minutes immersion is a safe time. Care with chlorine bleaches because they can corrode some metals. Heat is best. It only really needs 80 degrees for good disinfection to happen, but boiling is not a problem. You don't need a thermometer to tell you that water is at a disinfecting temperature if you can see it boiling. So this is an example of these two examples. On the left is bedpans being disinfected in a large bucket full of disinfectant. You can see there's not full immersion there. Those bedpans are not going to be effectively disinfected. On the right are bed pans within a boiling apparatus. There's a lid here that comes down and then the water boils. So you don't need direct contact between the bed pan and the water to effectively decontaminate, because the steam is also going to be at 100 degrees. So that's an example of very efficient, very robust and easily available bedpan disinfection. And lastly, surgical instruments. Surgical instruments should be sterilized by steam under pressure in an autoclave. If, for whatever reason, this isn't possible, there are two alternatives. Chemical sterilization, that is use of chemicals that can inactivate bacterial spores, or disinfection by boiling, high-level disinfection by boiling. Now, there are problems with chemical sterilization. Chemicals are there are lots of factors that can make the use of chemicals poorly efficient. But the factor that I want to focus on here is that the chemicals used are going to be toxic. They're going to be need to be rinsed off the surgical instruments afterwards. This will reintroduce contamination. They need to be rinsed and they need to be dried. Both of those processes can reintroduce contamination. Boiling will kill everything except bacterial spores. Pre-cleaning the instruments will remove the vast majority of those bacterial spores. It's highly effective and there's no need to rinse. And because the instruments are coming out of the boiler hot, they will dry without the need for additional contact with drying cloths to dry them. So if for whatever reason you can't sterilize surgical instruments by steam, then I would advise boiling over chemical sterilization. Thank you very much for listening. I'm happy to take any questions.
Thank you very much for that talk, Peter. Interesting theory, brilliant clinical practice pointers as well. We have a few questions from the audience. I'm not sure if you can see them in the chat window.
Yeah, I can see them. Let me start at the top. So you have made the point that it might be useful if anyone can explain endoscope decontamination in the Yemen.
So I suppose that's something that the attendees would be welcome to pitch in with. So what access do colleagues in Yemen have to endoscopy equipment, first of all, and how do you guys normally go about decontaminating the equipment you use? But while the audience is considering that,
all I can see are the requests for questions in the Q&A boxes. Old man with new technology problem.
Okay.
Right. Can fungal colonization of air conditioning systems be thought of as a source of infection in hospital settings, especially in operating theatres? Yes, it can be. Within air conditioning systems, these will recirculate air via a cold surface. There will be condensation on that cold surface, which will then drip into a collection, a drip tray, collection vessel, where it's then piped to an outlet. There will be collections of organic matter within that drip tray, and you will get fungal growth. So air conditioning systems, recirculating air conditioning systems, particularly within high-risk areas such as operating theatres, neonatal intensive care units, adult intensive care units, and burns, the drip tray should be regularly, thoroughly cleaned. That's the only thing that you can do with those. Question, we have lack of knowledge about types of contamination agents, disinfectant substance, according to we need. Yeah, what I can advise there is this is a problem that will vary from hospital to hospital about what resources you have and what challenges you have. It's got to be developed on a hospital by hospital base. What I'm advising is that you would use sodium hypochlorite, either liquid bleach or solid hypochlorite, which is usually sodium dichloroisocyanurate, as the main disinfectant for anything that's not going to be corroded. So most healthcare environmental surfaces decontaminated by bleach. Instruments ideally use heat, either as steam or boiling, or compatible chemicals. But this will depend on what chemicals you have available. Alcohol wipes are good, usually fairly available. Endoscopes, you would need specialized chemicals. Which precautions for hepatitis during endoscopy? The answer to that is the standard decontamination that I showed you after every endoscope use. So you can't just put the endoscope in a bucket of disinfectant between uses. It's the lumens that are going to need decontamination. Have we had any feedback on what facilities there are for endoscope decontamination in the Yemen yet?
We're just going through the chat now. Let's see what we've got. Okay.
So it's almost universal in the UK to use automated endoscope reprocessors, but it's perfectly possible to decontaminate endoscopes manually and efficiently.
So another good question from an audience member. What's the best, most efficient cost intervention to stop general transmission? I guess that might be a difficult question to answer in the context of what you're trying to prevent. What do you think, Peter?
You don't know what you're trying to prevent when you're preventing it. You need a strategy that can encompass anything. What's the best way to clean surfaces? Soap and water or a clinical cleaning wipe? Low risk surfaces. Okay. Let me rephrase the question slightly. If you clean a surface in a hospital, you will remove about 80% of contaminants. If you disinfect it, you will remove about 95% of contaminants. But if you go back and sample it an hour later, it will be recontaminated. So whilst there's a source of dispersion, whilst a patient is still present in a particular environment, then what you're doing around them is social cleaning, and you just need to try and separate one patient's space from another patient's space by decontaminating the equipment that comes out of there or decontaminating hands that come out of there. So routinely, all you need is soap and water, and then ensure good precautions between different patients. Once a patient has left a bed space, then before another patient occupies it, their chemical disinfection, such as hypochlorite, can be useful.
Thank you. I think that helps clarify one of the other questions, which was clarifying the difference between cleaning, sterilization, and decontamination. So we've covered cleaning and decontamination. Now, sterilization is much stricter in that means complete removal of all microorganisms, so nothing at all is present on that. Would that be a fair thing to say, do you think, Peter?
Yes. Sterilization should be absolute. The steam has to be able to reach every surface. So this means that if you're using a sterilization drum, it can't be packed too tightly, and things shouldn't be wrapped within that, because the steam won't get to the surface of the instrument that's wrapped. if you're using a porous load steam sterilizer, which actually evacuates the air by pulling a vacuum on the chamber before sterilization and then replaces it with steam, then you can wrap items.
One more open question from the Q&A section. Do we advise stopping screening and colonoscopies during COVID?
No, don't stop screening colonoscopy during COVID. It's with COVID, it's difficult. Precisely what defines an aerosol generating procedure is poorly defined, but it's not thought that you would get significant COVID aerosols from colonoscopy. Patients need screening. Don't discontinue it.
I think I would agree from the perspective of a clinician as well. Fundamentally, if your patient needs an endoscopy for whatever reason, don't let coronavirus be a barrier to that in of itself. People will still present with other medical problems, even at the height of a pandemic. So, I think that's everything covered in the discussion section. So perhaps we should move on to the next speaker. So thank you again very much, Peter. So everybody, Peter Hoffman from PHE, a brilliant talk all round.
Thank you very much. Bye.
Bye. So it gives me great pleasure to introduce our next speaker, who is one of the biggest names in fungal related matters in the UK and internationally. I could sit here all day and talk about Professor David Denning's accolades and achievements in the world of academia. And the biography I've been given for him is quite extensive. As an author of over 650 research papers and chapters, largely on fungal diseases, Prof. Denning has been in this game for some time. Amongst his more recent accomplishments, he was a highly cited author globally, 2018 and 2019, is the previous director of the National Aspergillosis Center between 2009 up to 2020, and now is the coordinator for the International Genome Sequencing Project for Aspergillus fumigatus. So Professor Denning will be speaking to us today about non-culture diagnostics in low and middle income countries. So without further ado, please, Professor Denning.
Thank you very much. Could you let me share my screen because so that I can just show you some slides. There we are, perfect, thank you very much. So I'm going to talk to you today about several topic areas, mostly related to non-culture diagnostics in low middle income countries. But I'm going to introduce the topic in various different ways so that we cover more ground. I want to tell you a little bit about Gavi, which is the Global Action Fund for Fungal Infections. I want to cover essential diagnostics in the WHO and that story, which is a relatively recent story. I want to deal with 4 topic areas within aspergillosis, which were one related to COVID, patients with chronic pulmonary aspergillosis, which looks a bit like TB, fungal asthma and Aspergillus bronchitis, and then some resources that may be valuable to you at the end. So we set Gavi up in 2013. It's really the only public voice for public health mycology in the world, and we've really interacted a lot with WHO in particular, but also some of the regional offices. I've been, for example, to EMRO and PAHO and CRO, and also with various agencies that are involved in diseases where fungal infection is a complicating factor. On a daily basis, we think there are about 13 million people at risk of dying of a fungal infection, which is related to multiple underlying diseases, including leukemia, critical care, HIV/AIDS, TB, fungal asthma, and so on. And annually, we think there are about 2 million deaths. We can't be quite sure because of the diagnostics are not there in many places, and therefore these diagnoses are missed a lot. but that would place fungal disease about the 5th biggest cause of death. But of course, it's almost always a complication of something else. So, you know, if your leukemia is out of control, then you might die of aspergillosis or mucormycosis. If you're in critical care with candidemia and renal failure, you know, usually there's multiple reasons why patients die. But we do know that nearly half of the HIV deaths around the world are due to fungal disease, principally pneumocystis pneumonia, cryptococcal meningitis, and in some parts of the world, histoplasmosis, and then there are rarer causes with talaromycosis, which is in Southeast Asia, and aspergillosis, which is global, but numerically smaller. So there are many, many patients, and most of these patients are not diagnosed still. Now, if we were Jeff Bezos or Warren Buffett and we could wave a magic wand and everybody could get the current WHO listed essential diagnostics and medicines, we think about 1.3 million of those lives would be saved every year. This, it's not 100% because patients have got severe underlying disease, but also because the diagnostics and treatments are not perfect. But this is still a lot of people whose lives could be saved with appropriate diagnosis and therapy. And if you compare fungal diseases with TB, malaria, you can see that there's really a big problem here which needs to be addressed. And the amount of attention that's gone into fungal disease compared with malaria and TB is much smaller. Having said that, the impact on reducing mortality in TB has not been very large. And I think part of the reason for that is that there's a lot of misdiagnoses of TB. So we see a world free from death and suffering from fungal disease. Our focus is particularly on health systems in low and middle income countries. And it's very much focused on diagnosis and treatment. And we're particular area of focus is the essential diagnostics and medicines, which the WHO has listed, which countries should be adopting if they possibly can. So here are just some examples of fungal infections from different parts of the world to give you a flavor of it clinically. So Penicillium marefi, it's actually been renamed now Talaromyces marefi from Thailand in HIV disease, coccidioidomycosis from Mexico, an aspergillosis patient with CLL from Pakistan, allergic fungal sinusitis from India, oral candidiasis from patients with AIDS, and in this case it was fluconazole resistant, chromoplastomycosis from Papua New Guinea, disseminated candidiasis in a very prem baby in the US, and tinea capitis in Uganda. And this disease, tinea capitis, is very common in Africa with probably about 130 million children affected. So it's really numerically a very big problem. So in 2016, an editorial in the New England Journal suggested that it was time for a model list of essential diagnostics. There had been an essential medicines list for many years, stretching back into the 50s, and it was updated every 2 years. But it was felt that there was a need for a diagnostic list. And some of these people you may know, but Jeanette Guano is a histopathologist at Emory, originally from Mexico, and Ali El-Bireri works now in Ethiopia. And what they wanted to span the whole range of tests, so not just sophisticated tests in university hospitals, but also very much point of care tests in, as they called it, physicians' offices and pharmacies. So the whole range of tests, and that was the beginning really of the effort by the WHO to undertake this work. So with Gafi, we convened a group in Kampala to discuss this in April 2018. And the WHO had convened a meeting the following week to discuss which tests should go into the essential list. And we issued a report which is online on our website, and what it was only about 2 weeks later that the WHO released their first essential diagnostic list, which was some basic things such as histopathology and measuring blood chemistry and full blood count and malaria smear and so on. Now, what we did was at that meeting in Kampala, we made a recommendation that the cryptococcal antigen test, the TB-LAM, which is the antigen test in late-stage HIV patients, blood culture, direct microscopy, fungal culture, which would of course be allied to bacterial culture, and histopathology should all be adopted. And we concluded that on the Thursday. We prepared a set of slides which were shown at the WHO SAGE meeting on the Monday, and these were adopted during that SAGE meeting at WHO. Since then, the WHO's initiated a process of application, which is in the autumn of each year, and then they make a decision the following year. And in 2019 or 18, we put forward histoplasma antigen, and it was approved in 2019. And then in 2019, we put forward aspergillus antigen, aspergillus IgG antibody, and pneumocystis PCR, and they were accepted. And it took a little longer because of COVID, but that list was issued in January this year. And so the most recent EDL, as it's called, is January 2021. Another of the tests that's on that EDL is a point of care test for CD4 cells. And obviously in the context of HIV, this is a very valuable measurement because particularly new patients coming in with HIV infection, it isn't always clear where they are immunologically. And if you know that they're less than 200, then there's a lot more investigations for opportunistic infection and prophylaxis that are required than if they're above 200. And so this point of care CD4 cell count measurement is been launched about a year ago by a small UK company called Omega. And this is one of the big evaluations of it, which was done mostly in South Africa. And you can see that if you, to look at all the tests less than 200, you have a 95% sensitivity, which is pretty good. The specificity is 82%, which means it's detecting some patients with slightly higher CD4 count. But actually the range is up to about 350. So once you get up to 350, almost none of the tests above that are positive, not quite zero, but close to zero. So this is one of the other things that's been listed recently as an essential diagnostic in the WHO list. So I've put on here all of the other tests that are listed as essential diagnostics, which are LFA devices or rapid diagnostic assays, as the FDA call them, RDAs. So some of them are combined tests. So you've got a test for syphilis and HIV 1 and 2. You can do a sepsis screen with CRP or procalcitonin, and they're separate assays. And then there's dengue fever G6PD deficiency, which is relevant for malaria prescribing, a group A streptococcal antigen, specific HIV 1 or 2 antibody, or antibody plus antigen. There's a hepatitis E antigen assay, and there's a surface antigen lateral flow test, and a hepatitis C antibody lateral flow test. You can detect antigens for influenza A and B. I've mentioned TB-LAM, and there's a new version of the TB-LAM coming out for advanced HIV, which is actually performs better than the current one. And so I think that new one will be a better choice later in the year when it's finally, they're reorganizing their manufacturing. So it'll probably be out in September, October. There's a malaria antigen, there's a SARS-CoV-2 antigen, and of course there are antibody tests, although they're not on the list for the WHO as deemed essential. There's a sickle cell test, a syphilis alone antibody test. I guess Chagas disease isn't a big deal in Yemen, but there is a test for that. There's also a diarrheal test for cholera, which is maybe helpful. And then visceral leishmaniasis, there's an antigen test for for that as well. So there's really quite a lot of really quite easy to use rapid tests now available. And this, I think, may be helpful to you going forward in terms of providing at least some diagnostic services for patients. So those of you in Yemen, I don't need to tell you about how difficult the situation is for you, and my heart goes out to all of you because it's really is very difficult, with 20,000 airstrikes and so on. And this piece in the Lancet Infectious Diseases in February this year describes a film which is available on BBC if those of you are interested in watching that, if you haven't already watched it. So I want to then switch into invasive aspergillosis because I want to talk a little bit about that and COVID. I realize that some of these centers won't be functional in Yemen at the moment, but the point of this slide is to show you that about half the patients in Europe with invasive aspergillosis are diagnosed or seen in intensive care. So we have often thought about this as being a neutropenic leukemia disease, and it certainly is that, but actually there's a bigger proportion who occur in ICU. And one of the reasons for that is this syndrome, which has been named CARS, or compensatory anti-inflammatory response syndrome. So you go into ICU with sepsis or some insult, major surgical insult, and you have a very strong Th1 response. And then to stop the body disintegrating with a toxic shock-like syndrome, there are control mechanisms put in place to suppress that Th1 response. And you get a lowering of the immune system as you come out of that Th1 response. And that system gives you this period when you're more susceptible to infection. So for example, candidemia is particularly common in patients who've had bacteremia, and aspergillosis particularly common in those who've had a significant insult of some sort. And if you look at COVID specifically, this retrospective study, which was published online fairly recently, looking at patients in France who were deteriorating. So they admitted 366 people to ICU, of whom 250 were ventilated. They got samples from about 108, most of whom were ventilated because it was easier to collect a tracheal or bronchial sample of those patients. They looked for Aspergillus by culture, PCR, galactomannan, and they also did a pneumocystis PCR because pneumocystis and COVID imaging is somewhat similar with a lot of ground glass appearance. And then they did additional testing with galactomannan on the blood with beta-D-glucan and some additional PCR testing as well. And 19% of the patients had invasive pulmonary aspergillosis in that context. So this is a deteriorating group of patients on intensive care, 19%. And the mortality was 71% in that group, compared with those who were also deteriorating, but didn't have invasive aspergillosis, and their mortality was about half at 37%. And this is a larger study in the same journal from Italy, Bartoletti et al., and they used two different definitions of what's called CAPA, that's COVID-associated pulmonary aspergillosis. And in both, whichever definition you use, there's really a significant reduction in survival if you have aspergillosis, from the blue line down to the red line, or blue line down to the red line on this side. So this is one of the major reasons why these sick patients are dying, is because of the problem with invasive aspergillosis in them. So how do you get to a diagnosis of these patients? Well, a CRP isn't much help. Many patients have invasive aspergillosis and have a normal CRP. A chest X-ray is not very specific, as I'll show you. A CT scan is helpful in many contexts, but not actually in the COVID-19 context, and I'll explain why. There's a lot of tracheobronchial disease, particularly in COVID, but generally in ICU. And you can see this if you do a bronchoscopy, if the patient's not absolutely critically oxygen dependent, and you can have enough time to look with the bronchoscope, you can see airways infection, and this is particularly common. And in that group, you'd expect the microscopy to be positive. You can sometimes have this with Candida or mucormycosis as well. It isn't always Aspergillus. The galactomannan on BAL respiratory samples is very helpful. The glucan, we don't actually know how good this test is. It's probably not terribly good. Antibody is probably late and therefore not good at an early diagnosis, but PCR is probably very good and maybe better than culture, and could be faster if the test is done rapidly. So here are two examples of COVID-19 imaging from patients with ground glass appearance in a focal area, posterior on the right, which increases quite rapidly over 3 days. And then you have also in this patient a slight change with a bit more ground glass appearing. And this is very typical. And this ground glass appearance is what you get also with pneumocystis pneumonia and sometimes surrounding lesions with invasive aspergillosis. And there are some very distinctive features of COVID-19 on CT scan. You've obviously got this ground glass appearance here, but here you've got an air bronchogram appearance, which is distinctive. And in this black area, you get air trapping, which is also distinctive. And you can also see this vascular enlargement in this slice. So this is obviously a scan with contrast. And this is also highly distinctive for coronavirus and not something you see in most other diseases. So that's also quite helpful. And when you look at a table of this is from about a year ago, you can see what's called the reverse halo sign, which is a feature actually of mucormycosis in some patients. They didn't, I think, have mucormycosis. And you can have nodules with a halo sign, which is present in about 18% of patients. And this is a very typical feature of invasive aspergillosis in leukemia. But you see this in COVID, and these patients probably didn't have aspergillosis. They just had COVID, in fact. You can also get other nodules. So there is some confusion here with these other features with fungal disease. But the vascular enlargement up here, you can see 82% had that. And this crazy paving pattern with intralobular septal thickening is also very common at 70%. So it's quite distinctive, COVID-19. Now, generally in ICU, the radiological features on a chest X-ray are really very unhelpful, but even on CT scan, they're not very helpful. So these are all patients with invasive aspergillosis, and the only one that would be sort of more distinctive is the bottom left with these nodules and a little ground glass around it, and another nodule up here. This is more typical of invasive aspergillosis, and if you see that, you should think about the diagnosis. The only other thing to say is that bilateral disease is fairly typical for invasive aspergillosis, but it isn't always the case, and other things, of course, can cause bilateral disease, as you know. So this is a very frank, two serious examples of tracheobronchitis. This is known as pseudomembranous tracheobronchitis, and this is usually fatal if you see this. But if the patients are treated very aggressively with voriconazole or isavuconazole, then they can recover from this, but it is tricky. And if you don't see this, and you can have a normal CT or a normal X-ray and have this appearance, this patient would die, I think, from this. And just to remind you that lung disease, prior lung disease, is important in invasive aspergillosis. A lot of the patients have pre-existing COPD, history of pneumonia, or history of asthma, or some other lung disease. And so this is a clue to the diagnosis in ICU. But you can also have invasive aspergillosis complicating COPD unrelated to ICU, unrelated to COVID. And typically that's related to steroid use, but not always. And many patients have been described with invasive aspergillosis who've not had either inhaled or oral steroids. So here is a shadow that is very typical, but you've also got multifocal disease, and this 2 or 3 areas of infection separated in time is a clue to the diagnosis. On the right-hand side here, you've got a little area of cavitation with a circular lesion. That's highly characteristic of Aspergillus and should alert you. And then you've got these nodules, which are in the bottom right here, which are also typical. So we published a paper recently estimating how many patients had invasive aspergillosis complicating COPD across the world, and the numbers are staggeringly high. And in Yemen, we think the number is about 1,100 to 3,000 patients a year. So there's probably this is probably the biggest reason for invasive aspergillosis in Yemen, and needs to be thought about in patients admitted with an exacerbation with gold stage 3 or 4 COPD. So the very best test for diagnosing invasive aspergillosis in ICU is an antigen test in the BAL. And in this older study, which was really the beginning of a lot of this work, there were 26 proven cases from autopsy, and they had sampled 110 patients who they thought might have aspergillosis. And the sensitivity and specificity of the antigen was close to 90%. For both in these patients. And that compared with a culture, which was positive in 40%, and a blood antigen, which was always negative. So again, getting BAL and doing an antigen is very helpful. And as I mentioned, there's now a point of care test for Aspergillus antigen. This is one of 2 tests. This is the it's not a galactomannan test. This is a slightly different antigen, and the test is easy to read. As you can see up here, you've got a control line and a test line with these 3 positive and this one negative, and again the same down here with the negative and 3 positives here. And this performs at about 70 to 80%, so it might be slightly inferior to the galactomannan measured by ELISA, but it's still a helpful test because if it's positive, then it's very likely to represent invasive aspergillosis. So just to summarize that, if you want to diagnose invasive aspergillosis, fungal culture is sometimes positive, microscopy is sometimes positive, and they're useful tests, but they're not very sensitive. The key tests are really the antigen, particularly on the respiratory fluids, or PCR if that's available to you. Blood is not so good. It's not very good in non-neutropenic patients, and in people on prophylaxis, itraconazole or posaconazole, they also usually have negative antigens. Some patients have a positive IgG antibody, and patients can seroconvert, but it's not a great test. They don't have an IgE antibody, and the beta-D-glucan may be helpful, but again, it's not in the one of the best tests. So switching attention from invasive disease to chronic pulmonary aspergillosis, which looks like TB, there's the initial diagnosis of TB is sometimes wrong, and actually it isn't TB at all, it's CPA. You can have a co-infection, particularly with TB or NTM infections. And you can also have CPA that can follow TB some months or years after the end of anti-TB treatment, particularly in those who have a cavity when they've completed their TB therapy. So there's 3 components of this. And here are 2 examples of TB on the left and chronic pulmonary aspergillosis on the right, which is unilateral in this case. So you have these soft shadows with a little bit of cavitation in TB. On the right, you have a bigger cavity, more obvious cavity with pleural thickening and some thick areas underneath the cavity. And this is much more typical of CPA than TB. And the patients present with features very like TB. They have a cough, they're short of breath, they lose weight, they're tired. There's a much higher frequency of coughing up blood in CPA than TB, although you can cough up some blood with TB. And you also more likely to have a chest ache or discomfort. You're much less likely to have a fever with CPA, whereas that's quite common with TB, but not universal, as you know. The coughing can be quite profound, and you can get a rib fracture, and you can have extra chest infections. And so you can have TB, aspergillosis, and bacterial infection as well. So you can have a triple infection issue, which makes diagnosis confusing and tricky. And coughing up blood, as I've said, is very typical, and sometimes it's quite marked, and patients can die of hemoptysis sometimes. And the key radiological features are pleural thickening, cavitation, and pericavitary infiltrate. So this is a man with sarcoidosis. You can perhaps make out abnormalities on the right-hand side here. On the left-hand side, there's a very large single cavity with a little bit of pleural thickening. It's not very marked, but you can see quite a thick wall medially and some inflammatory material, pericavitary infiltrates inferiorly. And so this is very typical for chronic pulmonary aspergillosis. Here's a more severe example. And this man, who originally was from India, actually had proven tuberculosis twice, which was fully treated and he got better. But then he developed more shadowing in his right upper zone. You can see his trachea is pulled way across. There's a lot of contraction on that side. Symptom-wise, he just had a bit of a cough, but not much. He was still working very hard, but he had a very high Aspergillus IgG antibody, and this is the test of choice in these patients. And he had a normal CRP and plasma viscosity. So again, you cannot rely on these inflammatory markers to rule out aspergillosis. You can get a fungal ball occurring, and this is what they look like if you take them out at surgery. And these are late features. This is all fungus in here. So this is like a truffle. It's a large amount of fungal growth, and it's been there a long time. And if you look at, this is a group from Pakistan who looked at this, you can see 13% of the patients had concurrent TB and CPA at the same time. And you can also see up here that diabetes is linked to this disease. About 30% of their patients are diabetic. And they also have patients with other various sorts of underlying disease, which isn't frankly immunocompromised, but they're not quite right. Although you can see even some of these patients had some neutropenia and chemotherapy there. We held a Gavi meeting, like the meeting we held in Kampala, but the one before that in 2016, trying to work out what the definitions of this disease should be for low middle income countries. And we published this paper. It took a little while, August 2018, in Emerging Infectious Diseases. Essentially this, and I'll show you what this requires in a second. One of the reasons that the diagnosis is missed is because cultures are not always positive. So a single sputum culture, even though you've got a very frank case like this one with an enormous pleural thickening and a fungal ball, and sputum being produced like this, this can be culture negative. And recently in the UK, we've gone to high volume cultures, and this has improved the fungal yield. So this is the methodology that was used by the Public Health Laboratory Service in the UK and routine microbiology, where you plate 1 to 10 microliters onto a fungal plate, and you got around a 20% yield in this series. And if you do a high volume culture where you plate all of the material on a plate, you get about a 50% yield. And so this is a much better yield. And in fact, it matches PCR in this context, although you get some positives by culture, which are negative by PCR, and vice versa. So in fact, doing both together pushes the diagnostic yield up to about 70-something%. So the key test that is required is an antibody test, which used to be called Aspergillus precipitans. And there is a new lateral flow assay for this as well. This is produced by a small company in France called LD Bio. And you can see the control lines are all positive along the bottom. You have a negative, positive, negative, weak positive and positive in these examples. And this takes about 30 minutes. It's done on serum, and the cost per assay is about €4 or $4. So it's really a good value. And compared with the standard UK methodology, which we send off to the lab, it's actually more sensitive and very specific if compared with blood donors. That specificity goes down in a respiratory clinic to about 85% because there are other reasons for a positive IgG antibody, including allergic bronchopulmonary aspergillosis, sinusitis, and in sometimes invasive aspergillosis as well. But it's still, the sensitivity at about 92% is pretty good. So what you need, and this came out of the work in Liverpool, the consensus meeting in Liverpool, is 3 elements. You need a chest X-ray that's suggestive of the disease. You need some symptoms, although sometimes they're fairly subtle, as I've indicated with the chap from India who had just a cough, and they're symptoms for at least 3 months. And then you have an Aspergillus IgG that's raised. And if you put all of those together, that's when you can diagnose CPA. And in this context, patients seen at the end of TB therapy in Indonesia, about 13% had a positive, had a CPA. But the symptoms alone aren't enough, nor is the chest X-ray enough, and nor is the Aspergillus antibody enough. So chronic pulmonary aspergillosis fungal culture is helpful, but particularly if it's high volume culture, microscopy is not so helpful. Antigen on BAL is helpful if you can do it, but you have to do a bronchoscopy. It's not quite so good on sputum because the cutoff level is much higher. Aspergillus PCR is similar to fungal culture. Antigen on blood is usually negative. The IgG antibody is the key blood test that needs to be done. Some of the patients have a positive IgE antibody, and a small number of patients have a beta-D glucan as well. So the final, nearly final group I want to tell you about today is fungal asthma. So these are patients in the outpatient clinic to the great extent, and there are 200 million asthmatics around the world, and amongst those, probably about nearly 5 million have allergic bronchopulmonary aspergillosis, or ABPA, that I'll explain, and over 6 million, and probably more like 10 to 15 million, have severe asthma with fungal sensitization. And it may be, but it has yet to be proven, that some of the deaths from asthma are in those with SAFs. And we have guessed that around half of them are related to SAFs, although actually that is a guess and we don't for sure know. You also get fungal asthma in children, and there are about 100 million children with asthma around the world. So the interactions between asthma and fungus are many. So we know that fungus and damp exposure at home increases the risk of developing asthma for the very first time. Dampness and fungus at home also increases asthma exacerbations. So you can get patients who were doing okay and they move into a new home where it's damp or there's a leak and they get asthma. There's an entity called thunderstorm asthma, which can take patients who are apparently perfectly well and put them into hospital with a serious event. Some occupational asthma is linked to fungal exposures. There's mushroom picker's lung and whiskey worker's lung and, malt worker's lung and so on. There's also a link between fungi and extrinsic allergic alveolitis as well. We know that fungal sensitization, allergy, is linked to severe asthma. We also know that antifungal therapy reduces asthma severity in most patients. So you can actually take a patient who's not doing well, poorly controlled asthma, and with antifungals, make them much better. When you breathe fungal stuff in, you do breathe in spores, but you also breathe in fungal fragments with preformed allergen on them. And so here are several of the fungi that cause fungal asthma. Alternaria is one, and there's a lot of antigen in the material around these fungal hyphae. Here's another example with Penicillium fumigatus here, and then Stachybotrys, which was related to bleeding of the lung in children in a cohort some years ago. So ABPA patients usually have severe asthma, but they may also have mild or moderate asthma, and occasionally no asthma at all. Patients with SAFs who have severe asthma with fungal sensitization, this is a definition that they have severe asthma, and there's some overlap between them and ABPA. So when you look at the prevalence of these two diseases, it's sometimes hard to separate these two groups completely. And not very far away from you, there was a study done 20 years ago now in Saudi, where they found ABPA in patients with asthma. So they had 23% of these patients had a positive skin test showing they were allergic to one fungus or other, and there were 6 patients overall. So they estimated that they had ABPA, or in this case, INTERYem, which is allergic bronchopulmonary mycosis, so some other fungus than Aspergillus, in 2.7%. So that's that rate of about 2.5% is what has been used globally to calculate the figure of just under 5 million people. When you look at studies on sensitization up to 2015 or so, you can see that there's large parts of Africa which haven't been tested. I guess the Yemen hasn't been evaluated either. And this is something that's helpful in terms of just understanding which fungi patients are allergic to, and that you have a baseline problem of sensitization. The skin test is very easy to do. It's inexpensive. This is a positive control with histamine. You have a house dust mite and cat allergy in this patient. This patient's not allergic to dogs, but they are allergic to pollens, and they're also allergic to Cladosporium, very allergic to Cladosporium, and that's the only fungus that they appear to be allergic to. And this is what you get sometimes, is this differences between different fungi in different patients. So to diagnose allergic aspergillosis, a fungal culture, which I haven't mentioned, is helpful, particularly a high volume culture. Microscopy is not very helpful. Antigens definitively not helpful. The PCR is probably similar to fungal culture. And then IgG and IgE antibodies seem to be particularly helpful, and particularly actually the IgE. This is the test that's of most value. There's some work that I've been involved in Uganda which suggests that IgG is not as helpful, although in India it is helpful. So I think there may be a geographical variation on the IgG. And then finally, just to tell you a little bit about Aspergillus bronchitis. This was the first report in the world of Aspergillus tracheobronchitis from a child who was apparently normal, who died in 1890 in Edinburgh, and had these plaques of fungus on the airway, which were very unusual and very distinctive. And they thought the child had TB, but there was no evidence of that. It may be that the child did have the influenza or respiratory virus, because we know that respiratory viruses increase your risk of aspergillosis. And here's another example of pseudomembranous tracheobronchitis in this example. And here are the x-rays. I think I showed you an x-ray similar to that. You can see left lower lobe consolidation here, which is obvious here. But this patient also had this lawn or complete matting of the airways with fungus. And that is a feature also. This is the worst end of the spectrum. But we described a group of patients with Aspergillus bronchitis without formal immunocompromise. Most of them, 86%, had bronchiectasis. So that's the strongest link with Aspergillus bronchitis is bronchiectasis. Sometimes they got mucus impaction. Some of them had a bit of asthma or COPD. And many of them were on inhaled steroids because they were getting increasingly symptomatic, and so the typical response is to give them more inhaled steroids and higher doses, and even some were on oral steroids as well. So they typically present with a productive cough, and sometimes they have this very thick, high volume sputum. It's really very sticky and difficult to cough out, and they complain of coughing spasms, which are really, really difficult to, and then they get this sputum out and they feel a bit better, but they're very breathless with it. About half the patients are really quite breathless. So an MRC score of 5 means that you're breathless talking or getting dressed. Some of them had recurrent chest infections, and we do see bacterial and fungal infection together. So you can have Aspergillus bronchitis and various bacterial disease infections as well. Some of them were tired, some had lost weight, and a couple of them had a little bit of hemoptysis. So this diagnosis is made with sending multiple sputum samples for fungal culture. Again, sometimes the microscopy is positive. The PCR is helpful because the cultures are sometimes negative in these patients. And these patients also will sometimes have a positive Aspergillus IgG antibody. And so that's a helpful clue to the diagnosis if you have it. So in conclusion, we've got antigen detection and PCR and imaging are the most valuable pieces of information for invasive aspergillosis. Aspergillus IgG may be helpful in the subacute invasive patients, so the patients with slightly less immunocompromised, and that group, they will often have an IgG. Won't always be true positive, but often they will. Cavitation Aspergillus IgG is very important for chronic pulmonary aspergillosis. I've not talked much about nodules, which look like lung cancer on a CT scan, and there actually a biopsy is really required to find that diagnosis. A total IgE, an aspergillus or other fungal IgE, and Aspergillus IgG are important for fungal asthma, together with skin prick testing if that's available. And this is quite inexpensive skin prick testing and pretty informative. And then for bronchitis, Aspergillus culture and PCR are the key diagnostic measures. So we run the Aspergillus website, which you're most welcome to access. It's got lots of patient stories and cases, lots of images, of huge, almost all the Aspergillus literature that's been published on it. We also run with it, and there's a lot of usage of this, of the website, which is helpful because there's lots of teaching aids and PowerPoint presentations and so on. There's also a drug interaction section, and we've just published a little paper about this as well, but you can search drug interactions with all the antifungals very quickly. And there's an app which you can download for an Android phone as well to do that. So particularly if you have patients on long-term antifungals, it's helpful both for you and for the patient to know what drugs they can and can't use. And we also run the LIFE website, which is another valuable thing, I think, which it's got lots of videos on it, which you can download and watch on diagnostics and how to use the drugs, and about the disease, so about pneumocystis and cryptococcal meningitis, etc. And that may be of value to you. So I'm going to finish, if I may, with a short video, which I think goes back actually to our Gaffey work, but I think that might be valuable too, because it's quite evocative, and I just need to find it and load it up, and then I will be right with you. Here we go. Let me unshare this screen and then share again. I hope you can hear it. Tell me if you can.
I'd love to kill you with a kiss. I'd like to strike you down with bliss. I'd like to tie you up in knots until your heart stops. I'd love to kill you with a glance. like to put you in a trance. I'd like to drug you with my scent and use you in the moment. I'd love to kill you as you eat. Pleasure would taste so sweet. I'd like to open up your skin and wander there within. I'd love to kill you by a stream where no one can hear my baby scream. And then I'd run away and be free, the sweetest victory. I love to watch you in your sleep, 'cause you don't have power over me. And when you're awake, I'm undone under your spell. In
Great. That's it for me. Thank you very much.
Thank you very much, Professor Denning, for that brilliant talk. I think the particularly useful highlights on the clinical aspects of the diseases, and as well as a great summary tables on the various applications of the investigations we have available to us. So we've got quite a handful of questions in the chat box for you. Can you see them, Professor?
I can, yeah, that's
Sure.
right.
I'll leave it to you to tackle them in turn then.
Okay, so Iman has asked, during our clinical practice in the pediatric hospital, patients admitted with TB who don't respond within 2 months of TB therapy, they think of fungal infection and start them empirically on antifungal therapy. So that's perhaps reasonable, but you can, if you can get this Aspergillus antibody test, that will be very helpful, I think. One of the problems is that fluconazole doesn't work for Aspergillus, so that's a useless antifungal. Itraconazole does, and so does voriconazole, which are both WHO essential medicines, but they interact with rifampicin. So if the patient's still on rifampicin, then there will be no itraconazole, no voriconazole in the blood at all, and so that won't work. So I think there is a challenge around doing that, but and usually it's a 3-week washout period between stopping the rifampicin and starting an antifungal before that liver induction disappears. So that would be reasonable. Now, in fact, aspergillosis, chronic pulmonary aspergillosis, is very rare in children. I've seen one report of a 10-year-old, one documented, and the youngest patient that we had coming through our service in Manchester was 18. So I think it's really quite a rare disease in children. So I think there is an issue around what the diagnosis is and whether they are genuinely fungal or not. Okay, so then Iman goes on and says, in addition to that, children who have bronchopneumonia and don't show improvement with multiple antibiotics, usually consider them as having an underlying fungal infection. So I don't know the answer to that. You may be right about those patients having fungal pneumonia, but it's rare to get a primary fungal pneumonia from Aspergillus and Mucor unless the patient's immunocompromised. Now, you can get histoplasmosis, you can get coccidioidomycosis, for example, and blastomycosis causing pneumonias in normal people. But to my knowledge, those are rare infections in Yemen and the Middle East. So I think that needs some more thought, this bronchopneumonia in children, about what the right thing to do is, basically. So another person has asked, in which asthmatic patient should you consider aspergillosis? Right, that's a very good question. So it's the poorly controlled patient, patients who come into hospital, patients with cough that hasn't resolved, and particularly if they're coughing material up. If there's mucus production, then that's a clue. Fungal plugs tend to be brown in color. So anybody with brown sputum would be a clue to the diagnosis. And any patient who has a chest X-ray infiltrate, which is new, might be mucus plugging. And that would be also helpful, I think. So those are the key groups about that. And then somebody else has asked, when would you consider preemptive therapy in neutropenic patients? Early in the process is the answer to that. So if you have a patient with persistent fever beyond 4 or 5 days and any chest or sinus symptoms of any description, so any chest discomfort, any cough, any nasal discharge, any uncomfortableness in the nose, those patients should really go off and have a CT scan of either the chest or the nose. We know chest X-rays are not useful in neutropenic patients for aspergillosis. They're frequently falsely negative. So really a CT scan is the key. And when you do your empirical antifungal, which would be reasonable, and people typically use an echinocandin or amphotericin, if you're able to do a bronchoscopy early, then you could do Aspergillus antigen on that. You should also be sending a blood Aspergillus antigen if you possibly can. Now, there's also on the other chat, the participant side, the point of care test is useful to use, Professor Denning, but what is the sensitivity specificity of these tests? So they vary by test as to their sensitivity and specificity. You have to look them all up. The application process to get a test onto the essential diagnostics list is pretty formidable. It takes 2 or 3 days to assemble all of the information and put it into their forms. And you have a double form, a sort of preliminary form and then a full form. And they want meta-analyses, utility, and so on. So they consider this very carefully. But the performance does vary by test, and you just have to look that up, I think, for particular tests. Somebody else has asked, are the essential diagnostics paid for? The answer is that the WHO does not pay for them. They recommend them. But in the context of HIV, TB, and malaria, the Global Fund, if it's put into the package for Global Fund funding or separately for PEPFAR or USAID or one of the other agencies, they will include these costs in your package. And we've just done an estimate for cryptococcal antigen across the world, and we think that to provide the world with cryptococcal antigen testing would be somewhere around $15 to $20 million everywhere. In Kenya alone, they spend 500 million on HIV care. So the cost of these tests is very small compared with the general cost of HIV around the world. So I think if they're not in the private sector, you have to buy them, but in the public sector, I think it needs to go through governments, basically. There's another question about, we hear about lateral flow tests for COVID. Right, so the antibody test is not terribly useful. It tells you if somebody's had the infection, if it's positive, and they're positive, that IgG is positive in 97%. So you can document the disease afterwards with an antibody test. The antigen test on a nasopharyngeal aspirate or on the nasal swab or throat swab is around 80%, 70 to 80% sensitive. So it's not perfect, but if it's positive, it's very helpful. There are a very small number of false positives with the antigens. And actually, one of the other things I've done is to develop a little a delivery company in the UK to sell these tests to dentists, because they didn't have anybody looking after them early in the epidemic. And so we've investigated this in a lot of detail, and the tests work pretty well for that reason. And when would you consider antifungal therapy for COVID ICU patients? I think it would be, given the frequency of 20%, I would be inclined to give treatment on anybody deteriorating on ICU. So that would be, what I would do is they'd be on ICU, they'd be probably ventilated. If they're not improving, I would feel comfortable giving antifungal therapy. Which one, the best treatments are probably, the very best, which is expensive, is probably zabuconazole, because it doesn't cause any cardiac difficulties and it's effective. But it is expensive, and that's a challenge, and I realize that. But I would also be bronching the patient or sending tracheal aspirates off for aspergillus and fungal culture at the same time, so that I knew 3 or 4 days later whether I'd made the right decision, and whether if there are side effects on the medicine, I needed to stop or not stop. So, so I think that's all. And then, can we diagnose pulmonary aspergillosis by a blood test with confidence? Yes. The galactomannan test in neutropenic patients is very helpful. 80% sensitivity if they're not on mold active prophylaxis, so they're not on itraconazole, voriconazole, posaconazole, then that's a good test. It's not perfect, but it's a good test. It's slightly better if you do it on the bronchoscopy. The glucan does not give you confidence, and in invasive but in chronic pulmonary aspergillosis, the antibody test is a very good test, and something that you should be doing. So those are my answers, and probably we should stop there. I don't know what you want to do, Nick, but that would be where I stand.
I think that's brilliant. I think that's a great place to stop. Thank you again for your time, Professor Denning, for a brilliant talk. So at this point, I think it's time for a break. We'll be starting again at 2:30 Yemen time, or in about half an hour's time. A few of our audience have asked for a link to join the INTERYem Infection Network, so my colleague has just posted that in the chat. So I think we'll put an end to the morning's events now. So thank you very much, Professor Denning, and to Peter Hoffman as well for your input.
All right, you're welcome. All right, all the best. Bye.
So for our attendees, we'll see you back here in about half an hour for the next round of talks. Thank you again for joining us.
Yeah. Do you hear me through Zoom? Uh-huh. Share screen. Okay, I see it. I see. Oh, wonderful. Because I was wondering if I missed something. Yeah, can I just check that the screen share works? You should see it coming. Okay, good. So see you in a few minutes, in 20 minutes. Okay, bye-bye, thanks.
Hello, do you hear me? Okay, thanks. I'll be waiting after the next presentation.
Hello, everybody. It's a great honor to start the second session of the conference. I'll start again. Hello, do you hear me?
Yes.
Oh, great. Hi, everybody. It's a great honor to start the second session of the conference of the last day today. And in this session, in the afternoon, we will have key speakers as well. The first speaker who will tell us about diphtheria is a well-recognized speaker and expert. Dr. Sylvain Bress is the head of the Biodiversity and Epidemiology Bacterial Pathogens Research Unit at Pasteur Institute in Paris. And he is also the director of the French National Reference Center for Diphtheria. And we know diphtheria is quite a difficult and challenging infection, particularly in Yemen. And unfortunately, there's still a couple of outbreaks happened in the last few years. So it's with great honor, I'll ask Dr. Bress to start his very teachingful and useful talk, please. Thank you.
Thank you. Let me see if you see the presentation fine. Yes? Can you confirm you see the screen?
Yes, we can. Thank you.
Okay, thank you, thank you. So hi everyone, and I'm very honored and pleased to be with you today. So my name is Sylvain Bress, and I work at Institut Pasteur. I've been there since 20 years, more or less, and since 4 years, I'm the director of the National Reference Center for Diphtheria. So knowledge about diphtheria is rather new to me, but we became involved in a collaborative study on the situation of diphtheria in Yemen by contacts with some colleagues in NCPHL. And this resulted in a very fruitful collaboration where we mixed epidemiology, clinical characteristics, and microbiology. And I will present you this today. So it all started with the alert that was given by WHO and other bodies somewhere in the fall of 2017, approximately in October 2017. And there were a number of cases of diphtheria that were recorded. And this number was abnormal with respect to the endemicity that is known, unfortunately, in Yemen for diphtheria. And this was especially observed in the governorate of Ib, with most cases at that time located in this governorate. So a bit later, this colleague of us called Fikri Dureab, who works in Germany, but is a Yemenite, he published 2 papers on the epidemiology of diphtheria in Yemen. One was about the resurgence of diphtheria due to population movement, and he analyzed the links between internally displaced people and the lack of public health measures with the incidence of diphtheria. And in the second paper, he also published the link between the impact of conflict and diphtheria, showing that vaccine coverage was affected by conflict, and then subsequently incidence of diphtheria was therefore rising. So we came into contact with Fakhri Durayab and Abdulillah Al-Harazi, and I'm hoping, and I'm sure actually I don't pronounce the names well, but nevertheless you can read them. And we got into contact with them via the collaboration of Ghulam Daban, who is based in Ontario, but is a Yemenite microbiologist, very aware of the situation in Yemen and willing to help. So he contacted us and asked us if we could help the NCPHL to analyze what was going on especially in terms of microbiology, but also in terms of epidemiology, together with Fakhri Durayab. So before going into the details of this large diphtheria outbreak, I would like to remind you some background knowledge about diphtheria, because this disease, although you may know it well in Yemen, is typically not well known in most parts of the world. So Corynebacterium diphtheria is the causative agent of diphtheria. We'll come back to that later. It's a human-to-human transmission mainly. And then diphtheria, in terms of clinical signs, presents as the classical respiratory infection with especially pharyngitis, but also tonsillitis or laryngitis. And then the characteristic of diphtheria is the presence of these pseudomembranes. And these can lead to larynx obstruction in some severe cases. Now, the diphtheria nowadays also presents as a cutaneous infection, in particular in terms of ulcers, where membranes can also be observed. And many of the infections that we see in our countries, at least in northern countries, let's say, of diphtheria, are caused by invasive and tox-negative infections, and I will come back to that also a bit later. So beyond the local aspects of infections, one particular aspect of diphtheria is the existence of systemic complications due to the circulation of the diphtheria toxin, which is produced by the pathogenic agent. And this diphtheria toxin then can cause damage, and in particular to the heart and to the peripheral nerves. In terms of control, diphtheria is mostly controlled by vaccination, which is performed with an inactivated toxin called the inotoxin or toxoid. And this is a purified supernatant, which is formalin and heat treated. For case management, diphtheria antitoxin treatment is also recommended, especially if systemic toxinic symptoms are apparent. However, there are side effects, especially anaphylactic reactions to horse sera, and also the availability of that is not high. The antitoxin is not widely produced at the global level, and so WHO maintains the stockpile of these products, but it's in limited amounts. And finally, antimicrobial therapy is a very important component, obviously, of the treatment of patients. And the first line agents are penicillin or amoxicillin and erythromycin, especially if there is allergy to beta-lactamase. So it's interesting to look a little bit back, and I took this slide from a CDC cartoon where you can see that in the 1900 at the beginning of the previous century, diphtheria was one of the main killers in terms of infectious disease, and especially in children. You can see the burden was 40 million. 40 deaths per 100,000. And obviously nowadays, this has completely disappeared, and even most of the infectious diseases have disappeared, with the exception of pneumonia or influenza, in terms of significant contributors to the burden of disease. But this is an overall cartoon that probably reflects more the situation in Western countries, and there is a lot of geographic heterogeneities in this picture across the different world regions, obviously. So in terms of epidemiology, diphtheria has really decreased, as you can see, in parallel to the increase in coverage of vaccination. These are the official coverage and the WHO estimates. And you can see here the number of cases, which has decreased regularly, with the exception of a large outbreak that took place in the ex-Soviet Union countries in the 90s. But remarkably, the current rate of diphtheria is rather controlled, I would say, in terms of global burden. This cartoon is taken from a recent review by Sharma and colleagues on diphtheria, which you can find in Nature Microbiology, I believe. And it shows the coverage of DTP3 in 2018, and highlights a number of large outbreaks that have been reported across the world in the last years. And Yemen is unfortunately one of them. So on average, there is an average of 17,000 cases reported to WHO every year. At least these were the figures in 2018. And as we know, diphtheria has a high case fatality rate, approximately 5 to 10%, and it can be even higher in small, young children. Often, diphtheria comes in the form of outbreaks. And today we will talk about the Yemen outbreak, obviously. So I just want to remind you also that there are a number of etiological agents of diphtheria. So the classical agent is really Corynebacterium diphtheriae, which produce the toxin. So we call it Corynebacterium diphtheriae, toxin-producing strains. This is the classical agent, which causes the classical respiratory clinical form, but also cutaneous infections, and the transmission is exclusively among humans. Most infections nowadays occur in low and middle income countries. So this is really the diphtheria strictly speaking. And then a number of other agents of diphtheria, like non-toxigenic strains of Corynebacterium diphtheriae, or a related species called Corynebacterium ulcerans or Corynebacterium pseudotuberculosis, have been described as and are considered as causing diphtheria by some definitions, because they produce, some strains of this species also produce the toxin. So, but you see for these two agents, the transmission is very different because it's a zoonotic disease in both cases. For ulcerans, it's mainly cats, and, this is in French, cats and dogs. And for Corynebacterium pseudotuberculosis, it's mainly a contact with goats and sheep, which will lead to lymphadenitis in humans. So by some standards, these other agents are considered as agents of diphtheria, but then it's diphtheria in the broad sense, not in the strict sense of the classical disease. And in terms of taxonomy and phylogenetic relationships, these different agents are related, closely related. You can see here a phylogenetic tree with 5 main branches, one here corresponding to Corynebacterium ulcerans, one here with 2 sub-branches corresponding to pseudotuberculosis, and then there is one main branch corresponding to Corynebacterium diphtheriae, as classically identified in the reference laboratories. However, recently this species was split into 3 species, in fact, 3 taxonomic species, one retaining the name Corynebacterium diphtheriae because it includes the type strain of the species, and this really is the classical agent of diphtheria. And then there are 2 novel species which actually we described in the lab. One we called Corynebacterium ruxi in honor of Dr. Room, who invented very early the diphtheria antitoxin therapy. And then the other species that was defined recently is Corynebacterium belfantii, which only includes so-called biovar belfanti variants of diphtheria. This is why we gave it this name, particularly to make it simple. So when we talk about Corynebacterium diphtheriae and outbreaks of diphtheria with toxin-producing strains, it's mainly this sub-branch here, but not the 5 other subgroups. In terms of ecology, as I already mentioned, diphtheria is mainly human-to-human transmission. We seldom find it in animals, although this occurs, for example, in horses or in dogs, but we believe that most of the transmission is human-to-human. And it's, as I said already, this is very, very different from ulcerans, which in fact is more common than diphtheria in France, for example, and which is always transmitted from dogs or cats in humans. And there is no human-to-human transmission of ulcerans. So it's interesting when we talk about ecology to remind that there was a previous outbreak in Yemen. This was back in the years 1981 and the beginning of 1982, where there were 149 cases. And interestingly, the risk factors were obtaining drinking water from a wheeled carrier and also consumption of factory-made yogurt. And there were a number of reports of diphtheria outbreaks or cases linked to dairy products. So that's interesting to note, because it may be that in some cases, Corynebacterium diphtheriae can contaminate these either water or this type of food. So I don't want to spend much time on this. Just to remind you, the diphtheria toxin is an AB toxin with 3 domains, in fact, 2 fragments, 3 domains. And the catalytic domain, C domain, is responsible for adiporibosylation of elongation factor 2 inside the human cells, and this stops protein synthesis. So the cells die very quickly. And the diphtheria toxin is one of the highest potency toxins known. It's lethal at these doses, as you can see here. And the toxin, as we already mentioned, is responsible for the distal signs of diphtheria, especially on the heart and nerves. So to study diphtheria isolates, it's important to define, first of all, if they carry the tox gene, which encodes for the diphtheria toxin, but also if the strains produce the toxin. This is a 2-level characterization, because some of the strains carry the gene but don't produce the toxin because they carry a disrupted version of the gene. And so on the one hand, we detect the presence of the tox gene, typically by PCR. And on the other hand, we do a so-called ELEC test, which is immunochromatographic precipitation, where you have here the antitoxin and here the strains that are deposited. And if you see a precipitation arc, that means the strains produce the toxin. Here, in this case, for example, you have a negative strain and 1, 2, 3, 4, 5 positive strains, which produce the toxin. So the strains that don't produce the toxin are called NTTB, for non-toxigenic toxin-bearing diphtheria strains. So in France, we in the lab, we characterize diphtheria strains in a number of ways. So typically, the strains are sent by the labs because the mandatory notification of diphtheria in our country. And so in this lab, we do the molecular diagnostic by real-time qPCR and of the tox gene and some species-specific targets. We also isolate diphtheria from clinical samples using the Tinsdal medium. We perform identification, typically by Malditov on single colonies. And then we also look at the production of diphtheria toxin and perform some biotyping. Finally, we also perform antimicrobial susceptibility, and recently genomic sequencing is also routinely performed. I mentioned this because this is a kind of standard diagnostic lab process for diphtheria. And just to give you an idea of the epidemiology of diphtheria in France, and this will end my long introduction on diphtheria, we are observing a clear and quite dramatic increase in the number of diphtheria strains that are isolated in France. These are the blue bars. The dark blue are the tox-positive strains, and most of these isolates come from skin lesions rather than classical respiratory infections. And I would like to underline the fact that this is mostly a sporadic rather than epidemic pattern. So typically we don't know of links between epidemiological links between these different cases. So for those of you who are aware of the biovars in diphtheria, we recently showed that the biovars actually correspond largely to two major phylogenetic groups or branches within the overall diversity of Corynebacterium diphtheriae. But I don't want to spend more time on that right now. And interestingly also, it's interesting to see the distribution of the toxin across the phylogeny of Corynebacterium diphtheriae lineages. So the tox-positive strains are denoted by the red stars that you can see here or here. And interestingly, many of the sublineages of diphtheria are tox-positive, but many also are tox-negative, and they are completely intermixed in the tree. Some of these tox-positive strains lose the production of the toxin, as we discussed earlier, and these are denoted by these yellow circles. If you want to know more, you can look at the paper that was published by our group recently. So back to Yemen and diphtheria. So the diphtheria outbreak, just checking time. So just to remind you, the objectives of the study were to characterize the epidemiological, clinical, and microbiological features of the outbreak. This cartoon here shows you the epidemic curve that was reported in Yemen up to March 2021. So unfortunately, the outbreak is still going on as we speak. So the design of our study was a cross-sectional, including molecular epidemiology study. We relied on health facilities and the rapid response teams of the surveillance department for case reporting. And Fekri Duriab used and did his PhD actually on the utility of this system called the Electronic Disease Early Warning System, which takes place in Yemen. If you want to know more, you can look at his PhD document, which is available online. And then the line list of diphtheria reports were used for governorate level descriptions that we will present later. Finally, we looked at vaccination coverage and estimated that using the 2017 and 2018 annual reports of the National Expanded Program on Immunization. So we defined a probable case of diphtheria according to WHO definition, which is an adherent membrane and one of laryngitis, pharyngitis, or tonsillitis. And a confirmed case was one of these probable cases from which a Corynebacterium diphtheriae isolate was cultivated. And this was done at the Yemen National Center of the Public Health Laboratories, which I call NCPHL in short. So the probable cases from EDUs were from week 22 of 2017 up to week 23 of 2020, so nearly 3 years. And this work was done as part of routine case management under an emergency response mandate from the government of Yemen and was supervised by the scientific committee of the NCPHL. The NCPHL collected samples and isolated strains and transferred some of them to the French National Reference Center for diphtheria, especially for genomic sequencing, but also for confirmatory identification. So in terms of microbiology, 888 samples were taken from probable cases. For 340 of these, a culture was confirmed as Corynebacterium diphtheriae, and out of these, 100 were selected to be shipped to Paris. Of these, only a bit less than half were in fact positive in qPCR. This was a bit of a surprise, and we think this is due to bad storage conditions before sending to Paris. And 42 isolates and 1 duplicate, so that's 43 isolates, were in the end purified and characterized. So for these 43 isolates, and then we added 1 more isolate from Belgium because it had very closely related characteristics in terms of genotyping. We performed these different methods that I presented already a bit earlier in my introduction. So in terms of results, we counted 5,701 probable cases, which you can see here in terms of distribution across the 4 different years. And when we look at the epidemic curve, we realized there were 3 waves, perhaps. At least we divided these into 3 periods that correspond possibly to waves, but we are not completely sure. These are waves of the outbreak, or simply reflect some perhaps discontinuity in sampling or other effects of the conflict, for example. So we want to be very prudent in terms of in calling them waves. So the attack rate was 6 per 100,000, 6.3 in the first period, and almost the same attack rate in the second period. For the third period, we didn't have the data to calculate the attack rate, but we had a very similar pattern. In total, there were 330 deaths recorded, and this corresponds to a case fatality rate of 5.8%. In terms of geographic spread of the outbreak, we observed a start in Ypres, as was already reported, and then a diffusion across the country during the next periods. This subset of this map here shows you the geographical origins of the samples, so the 888 samples that were taken by NCPHL colleagues. So basically there is a wide geographic distribution of the outbreak and a distinction between distinct periods. If we look carefully, for example, the density is different between the different periods of time. So in terms of epidemiology, we can conclude that this is one of the largest contemporary outbreaks of diphtheria. There are outbreaks ongoing in other countries, like in Bangladesh, for example, and in Venezuela, but probably this is one of the largest outbreaks, unfortunately, for Yemen. The reporting is very likely to be an underestimate due to the conditions, and also geographically, the sampling was quite uneven. Due to the conflict and the divide between the north and the south of the country. And there were 3 periods which we may want to equate to epidemic waves or not. And the valleys in the distribution, interestingly, correspond to the Ramadan month of May or June. And perhaps there is an effect of this. And perhaps also there is an effect of conflict situation, which has hampered the sampling in some cases. In terms of clinical features, this outbreak is quite typical for a diphtheria outbreak. We found that, well, pseudomembranes were very frequent, but this was one of the criteria for definition, for probable case definition. But also we found swollen neck in many cases, more than half of these. And also the patients were young, which is typical for diphtheria outbreaks. In terms of vaccination, we noted that across the different years, 2018 and 2019, there was no difference in the rate of vaccinated cases. It was 57 versus 59%. We also didn't find difference in disease expression between vaccinated and non-vaccinated patients, which is a bit surprising. The median age of vaccinated patients was 10 years, of non-vaccinated patients was 13 years, so this was significantly different. And most of the probable cases were in children aged 5 to 15 years, with a median of 12 years. So this slide shows you the rate, the coverage percent of the third dose of the pentavalent vaccine in Yemen in 2017 and 18, sorry. And you can see that in several of the governorates, the coverage is lower than 80%. That means which is the the threshold considered to be protective in terms of collective immunity. So clearly there are a number of governorates where the situation was suboptimal and would have favored the dissemination of Corynebacterium diphtheria and the expression of the disease. So perhaps this slide is the most important of the entire presentation that I'm having now, because we observed a very interesting pattern where the proportion of children that are aged from 0 to 4 years old decreased between the two first periods. You can see this red curve here, which was quite high in the first period and quite flat in the second period. And what happened during these two periods was a vaccination campaign, which started in November 2017 until March 18, a mass vaccination campaign that targeted nearly 3 million children aged 6 weeks to 15 years. And we believe, this is a hypothesis obviously, but we believe what we see here may be an effect of this vaccination campaign, which targeted mostly the young children. And here you can see the proportion of children between the two periods, which for this category here dropped significantly between the two periods. In other words, but this is not a firm demonstration, but it's encouraging to see that these vaccination campaigns may have had an effect, especially on the young children. So in terms of ongoing or further vaccination campaigns, we noted that in 2019, diphtheria vaccination was also done in 186 districts of the 12 northern governorates. 1.2 million children aged 6 weeks to 5 years received the pentavalent vaccine, and 2.2 million children aged 5 to 15 received the tetanus diphtheria vaccine. Vaccination against diphtheria in selected districts of southern governorates and SADA started also in July 2020. And however, despite these efforts to control the disease, cases are still being reported up to March 2021, which is the most recent data that we have. In terms of microbiological analysis, so we, as I said, microbiological confirmation was sought for 888 samples referred to the NCPHL. This was from 2018 until 2020. Samples characteristics were largely similar to probable cases. You can see the features, for example, of the age of the probable cases versus the age distribution of the samples that were either confirmed or non-confirmed, and it's quite similar. The history of previous vaccination was also very similar between probable cases and non-confirmed cases, and confirmed cases. It's not significantly different, which is surprising, as I said already. So also interestingly, most patients were reported to be receiving antibiotic therapy at the time of throat sampling. So meaning the culture of the specimen might not have been optimal if the bacterium was already affected by antibiotic treatment. So of the 836 cases with available results, 340, which is 41% only, were microbiology confirmed by a positive diphtheria culture. And 100 of these cultures were sent to Institut Pasteur. You can see here the position in the timeline of these 42 isolates that were cultured in Pasteur. So they mostly cover the second period. So in terms of microbiology at Institut Pasteur, we could confirm that most of the isolates were tox positive, but there were four tox negatives, and all the tox positives were ELEC positive, so they produced the toxin when they had the gene. So interestingly, we looked also at the phylogenetic diversity of the strains, and we realized, to our surprise, that there were 6 main phylogenetic lineages of Corynebacterium diphtheriae contributing to the outbreak. So it's not a single strain; it's really a multiplicity of strains, and these strains are heterogeneous. You can see here in columns different features of the strains, including the presence of the tox gene. And these are the phenotypes of resistance. So you can see that some strains are resistant to penicillin, but this is very low-level resistance. Some strains are resistant to tetracycline, some others are resistant to trimethoprim. And here are a number of virulence factors. And you can see that the distribution of the virulence factors in the strains is also quite variable. So we had 6 phylogenetic lineages, and importantly, most of the strains were susceptible to most antimicrobial agents, including penicillin, amoxicillin, and erythromycin. But we also observed 2 strains resistant to quinolones. You can see them here. They were mutated in the targets of the quinolone antimicrobial agents. So we also looked at the genotypic comparisons of the strains from Yemen with other world regions from which we had genomic sequences. And we found that lineage A strains were sometimes associated to strains from Belgium, for example, the strain DIPT 045, and also sublineage B and C, which are here on the tree, B was genetically very close to Eritrean isolates, whereas C and E were genetically close to Somalian isolates, which clearly suggests a regional dynamics of spread of diphtheria strains. This is a more detailed view of the phylogenetic relationships. For the sake of time, I will not go into the details here, but this shows cross-governorate transmission. For example, you can see the same genotypes in different Yemen governorates, which are colored in different colors here. We also looked at the temporal dynamics of this outbreak in terms of phylogenetics, and we could place the last common ancestor of sublineage A, for example, in March 2015. In other words, the diversification of the outbreak strain that is the most abundant in Yemen started much before the recognition of the outbreak. So probably the outbreak was ongoing much earlier than it was detected in 2017. And this is one of the main outcomes of this phylogenetic analysis. Also, this shows that there are multiple chains of transmission because these lineages are quite diverse. So there are clearly independent chains of transmission during this outbreak. So it's a multi-clonal outbreak, very clearly. So conclusions, at least 6 unrelated phylogenetic lineages. This shows that multiple occurrences of diphtheria reemergence or introduction have occurred in Yemen. There is a silent diversity reservoir of Corynebacterium diphtheriae, which might persist despite vaccination, because vaccination is designed to protect against disease expression rather than colonization and transmission. And 2 closely related diphtheriae from Eritrea and Saudi Arabia were identified, and cross-governorate spread was also noted. So my main conclusion would be that a more systematic application of genomic sequencing would allow the geographical dynamics of diphtheria to be defined much more precisely. This is just a hint that there is some regional transmission, but clearly not at the detailed level that we need to really act on transmission. Other conclusions from the genomic study are that there is a heterogeneity in terms of virulence genomic features, but we don't really know the phenotypic or clinical consequences of this at this step, except for the toxin gene presence, obviously. It was interesting to see that some isolates were tox negative because they were also isolated from typical diphtheria cases, which was the criteria to sample these patients. And so it's well known that tox negative isolates can cause diphtheria-like symptoms, at least the respiratory symptoms, obviously not the toxigenic symptoms. Interlineage heterogeneity in iron acquisition, adhesion, and colonization capacities could underline epidemiological or clinical differences. We have seen differences in the genes that encode these systems, but we don't know at this step if there are clinical impact of this heterogeneity. And we also noted, I didn't describe that in the results, but we noted that strains, well, the patients infected with sublineage A isolates tended to be younger and also tended to have a more frequent neck swelling. This was statistically significant, borderline. And so, however, because neck swelling is more commonly observed in young patients, so we cannot really separate sublineage and age effects in this case. So in terms of antimicrobial susceptibility, I would say that the main recommended agents, penicillin G, aminopenicillin, and erythromycin, are active against diphtheria isolates circulating in Yemen. Quite an important conclusion. And in general, antimicrobial resistance is not frequent in diphtheria, but it happens. Antimicrobial susceptibility profiles were heterogeneous with a strong phylogenetic sublineage effect. And there was, and this is one of the caveats of the study, a possible selection effect by antibiotic therapy prior to sampling, as there was a high rate of antibiotic usage, in particular penicillin or macrolides before throat sampling. I would like also to underline the limitations before finishing. There are a number of limitations to this study. The first one is that available samples of diphtheria that were sent for biological confirmation do not provide a complete picture of this outbreak. The samples were referred to NCPHL, and the samples that were referred to NCPHL were distributed across a large time period, but the governorates in southern Yemen were largely underrepresented. 91% of the confirmed samples came from northern governorates. The laboratory work in Yemen yielded a low rate of biological confirmation, which we attribute to operational and technical difficulties. And half of the samples sent to Pasteur were subsequently found to be negative. And we thought a lot about this together with the Yemeni colleagues, and a likely reason is the inappropriate culture conservation. There were some shortage of electricity, and so the congelators did not, they returned to room temperature, so to say, and so the freezing conditions were not respected. So we saw a high phylogenetic, genomic, and phenotypic variation of the strains, and so this underlines that real-time characterization of isolates at the level of individual patients could therefore be relevant for clinical management and also to define strategies of vaccination catch-up or transmission tracing during diphtheria outbreaks. So this underlines the need for laboratory capacity, which definitely needs to be reinforced in outbreak settings. And in the context of increasing disruption of vaccination campaigns and shortages of diphtheria antitoxin, studies into the determinants of local persistence of diphtheria and its spread at regional or global scales are needed to better control the re-emergence of diphtheria. So I'd like to acknowledge the contributions of many colleagues. First, the colleagues from Institut Pasteur in Paris, so both from the unit Biodiversity and Epidemiology of Bacterial Pathogens, of which I'm the director, and also the National Reference Center for Corynebacteria of the Diphtheriae Complex. For short, we say the National Reference Center for Diphtheria, which is hosted in our unit, in research unit. We also got tremendous help from mathematical modelers, in particular Noémie Lefranc and Henrik Sallier from Pasteur, and also from bioinformaticians for the genomic analysis, Alexis Crisciolo and Julien Guglielmini. The funding was, there was no specific funding for this study. It was institutional funding from Institut Pasteur, from the French government program called Investissement d'Avenir, and from the NCPHL, obviously through the work of the colleagues, the employees of the NCPHL. And last but not least, I would like to thank 3 persons from Yemen, Fikri Durab, Ghulam Daban, and Abdullah Al-Arazi, who I mentioned already, who were really central to the success of this great collaboration. There are other colleagues from NCPHL and the Ministry of Public Health and Populations that you can read here. And you can see here that we have this study under INTERYem, and it should be out very soon now. In a few weeks in Lancet Microbe, you will have access to it. So all the details of what I've presented will be available very soon online. And with that, I believe I have finished, and I thank you very much for your attention.
Of press for this very informative and very teachingful presentation. I got here a couple of questions from the audience. And so Professor Imam Basdig is asking about the reason, if you would like to comment about the reason behind, to explain that there's no significant difference between clinical presentation of children who were vaccinated and those who were not vaccinated. Does it mean that the vaccine doesn't offer any sort of minimal protection against the disease? If you'd like to comment about that, please.
Yeah, thank you very much for the question. It's a very important question. It's puzzling indeed. One of the explanations we thought about, but we are not really sure how much it impacted the results, is that the vaccinations were perhaps not complete, and there was no booster maybe in some of the cases. We didn't have these details, but we know from discussions with our Yemeni colleagues that in many cases the vaccination was incomplete. And so that may explain at least partly what we found. There was some tendency for some clinical characteristics to be different, but never statistically significant. So this was a cross-sectional study. The vaccination status was probably recorded sometimes orally, just do you remember if you are vaccinated or not? There was no vaccination booklet as we say here or in other countries. And so perhaps also the quality of this information was not totally accurate.
Great. Actually, there are a couple of questions here, but mostly answered within the talk. And there's another question, just if you'd like to comment about, it says currently azithromycin is recommended on the first day, 10 milligram per kg per day, then followed by 5 milligram per kg per day for the last 4 days. Could you please kindly comment on this treatment regime, please?
Yeah, so I should have said, I should have said that I'm a PhD, but I'm not an MD, right? I'm not a medical doctor. So I'm not going to give any advice or comment on treatment regimens, because that would be beyond my my mandate and also beyond my knowledge. So I'm sorry, I cannot.
That's great. I think at this stage, I would say very, very much appreciated such a nice and very informative talk. We are very honored to have you with us today, and thank you so much for your contribution. Thank you.
Thank you very much. And you know, it's the first time I present this study. And it's also the first time I presented to a Yemenite audience. So for me, it would be very important to have feedback. So
Sure.
please, all the auditors, please feedback to me either by Twitter or by email or by whatever channel you may think of, because we are far from having, you know, deciphered everything about this outbreak, and there are many unknowns still.
Absolutely. Thank you so much again.
Thanks a lot. Thanks a lot. It was a pleasure.
We will now move to the next talk, and it's an honor again to invite our next speaker, who's also a key speaker, Professor Khaled Abdulaziz. He's a professor of public health and preventive medicine at a leading university in the Middle East, Ain Shams University. And he's an expert with collaboration with WHO and other organizations in preventive and public health medicine. And it's very nice actually to hear that we are talking about elimination of a disease, which is really quite uncommon. So with great honor, I would like to invite Professor Abdulaziz to tell us about the elimination of lymphatic filariasis in Yemen. Dr. Abdulaziz, the mic to you.
Thank you, Dr. Khaled. Thank you. Can you hear me?
I can hear you clearly, yes. Thank you.
Thank you very much. I'm quite honored to present this talk in this really well-organized, as we say, conference. I am Professor Khaled Mahmoud Abdulaziz. I am a professor of public health in Ain Shams University, Faculty of Medicine. I've been dealing with, or I've been in experience with lymphatic filariasis since 2001, and I have shared in elimination of lymphatic filariasis here in Egypt. And I'm happy also to inform you before the start that you have eliminated lymphatic filariasis from Yemen as of 2019. The disease was officially eliminated from Yemen. Can you see the presentation, Dr.?
Yes, we can.
Okay. The start of the talk is I will go through the I will go through the history of lymphatic filariasis in Yemen, and then I will start by how the National Lymphatic Filariasis Elimination Program started in Yemen, and then what was the program achievement in Yemen in terms of mapping, in terms of mass drug administration, how this stopped the transmission, and then the impact of mass drug administration on infection. And then we will see some of the activities also of the program as vector control and monitoring of MDA coverage and MDA evaluation. And then I will talk about the surveillance of disease after the stopping of the NTA. And lastly, the morbidity management and disability prevention done. And I will give a hint about the resources and partnership of this program. Starting by the history of lymphatic filariasis, Yemen is known endemic country for onchocerciasis. This is definitely true, and we know that onchocerciasis is endemic in Yemen for long years. The start of the story of lymphatic filariasis discovery of lymphedema cases started in Scotra Island. Scotra Island is one of the early stage of finding the endemicity of the disease. They found some cases, but unfortunately there was no laboratory confirmation about the cases. We cannot conclude that this lymphedema is linked with lymphatic filariasis. There was also acute manifestation in the people inhabitant of Scotra Island, like erythroangitis and recurrent acute attacks were observed in patients with injuries. Patients with clinical signs of lymphedema in those areas, of course, there is no diagnosis and there is no progression to elephantiasis. We're giving diacylcarbamazine citrate daily for 12 days as a treatment regimen for them. Because chronic cases were not formally registered or examined for microfilariemia or MF, lymphatic filariasis, or in short LF, was not recognized as a major public health problem in Egypt until the year 2000. The year 2000 marked the start of our story, the start of proving the endemicity of the disease, and the start of building up the national program for elimination. To make this confirmation about the endemicity and about the disease transmission, we had to search for the vector. The vector, the lymphatic filariasis vector, was still not known until 2005. We did researches and we find that the vector for transmission of the disease in Yemen was Culex quiniquae faciatus mosquito, which was identified as the main vector for lymphatic filariasis on Scotra Island based on detection of Vachura bancrofti DNA in these mosquitoes. This is the most abundant mosquito in semi-urban areas and temperate regions of the country and thrives in highly polluted indoor and outdoor cesspits and cesspools. cesspits and cesspools اللي هي البيارات بتاعت البيارات او الحاجات اللي هي فيها الدرينج بتاعت the drainage of the waste of product of the houses was in cesspits and cesspools. So the mosquito thrived heavily on these cesspits. The National Elimination Program for Lymphatic Filariasis, or NLFEP, had its goals and structure starting in 2000. In year 2000, the Ministry of Public Health and Population in Yemen initiated the elimination program and appointed a national focal point. From the start of the program was fully integrated with the National Leprosy Elimination Program in TAS. Most of the neglected tropical disease elimination program has to do, as we know, integration or mutual benefit. The National Elimination Program needed the National the National Leprosy Elimination Program in TAS to do the morbidity management or the final chapters of the program, as we will see in the end of this talk. The eliminations of the Leprosy Elimination Program is supported both by the German Leprosy Relief Association and the Yemen Leprosy Elimination Society. The elimination program infrastructure, or the National Lymphatic Filariasis Elimination Program infrastructure, included a network of rural health units and public health units where workers and volunteers provided health services. The program included coordination in each governorate, physicians, nurses, paramedical health workers, and trained volunteers for drug distribution and other NDA activities. As we will see later, the NDA, or Mass Drug Administration, has a lot of activities, and trained volunteers and healthcare workers also contributed to the success of this program. Now, let us see this life cycle of Vachura bancrofti lymphatic filariasis. As we will not go into multiple details here. The disease is human-to-human transmission through the bite of the vector, which is the mosquito, as we said, the Culex coinicae facitus. And we can see here there is a stage, there are stages in human from the biting to the adult stage, and then the release of microfilariemia, which is the diagnostic stage. The microfilariemia is then taken up by the mosquito to have three different transformation to L3 larva, and the cycle begins again in another person. The cycle, as we see, we have here the blue arrow cycle and the red arrow cycle. The main event for us to be successful in elimination is to cut these two cycles. How to break the blue cycle from the red cycle. This is done by, as we can see here, this black line. We want to do the interruption of transmission. We want to treat all the people that have the microfilariemia in their blood, so that the mosquito will no longer have this microfilariemia and will no longer infect other people. This is what we call interruption of transmission through the mass drug administration, or giving the drugs that we choose for treatment to all the participants or all the people living in the village or the endemic area. And small percentage of the success will rely on vector control, or how to decrease the number of mosquitoes for transmission. Now let's look at this graph that was picked from PDF for the elimination from the start of the WHO recommendation. They say this is the map or the roadmap for doing elimination program. First, you have to do mapping. Mapping, which means how to discover the villages or the areas that are endemic for the disease. This is the key first step for success, by doing surveys and to identify the areas by microfilariemia microfilariemia or the diagnostic stage above 1%, or antigenemia, or we have lymphatic filariasis antigenemia above 1%. All the found or discovered villages will be included in the program. Then we apply the next stage, which is the mass drug administration. The program consists of 5 different rounds, or 5 rounds of administration of the drug for 5 subsequent or 5 consecutive years. And then after the 3rd or 4th year, we will do a survey called transmission assessment survey to know if the program is successful. We are now in our path to achieving our elimination goal of 1% or no. If the program is successful, we will stop after 5 years. If the program is not successful of mass drug administration, we will continue for 2 or even 3 years more to achieve our goals. And then we will stop the MDA and we go to the post-MDA surveillance, which is the last stage, or the deep green stage. We will stay 2 to 3 years after stopping the program, and then do our first survey, which is called test 1, and then we will wait 1 year more and we'll do test 2. And if both test 1 and test 2 were negative for this area, we say this area has reached elimination, and we are now verifying our elimination in this area and check this area for elimination, and the end of our story or the end of our misery is now reached. So how the elimination program was started during 2001. There was initial institutional analysis was conducted, distributing a questionnaire to physicians, primary healthcare workers, and community leaders. The aim of this questionnaire survey was to identify lymphatic filariasis suspected areas, high mountainous areas, or deserts, or other areas, and areas with no historical evidence of the vector or clinical cases were excluded from the mapping process. Also, there was lot quality assurance mapping with, in the 65 eligible districts, identified 8 implementation units or districts for MDA. We now will apply our mapping strategies to identify 8 units or 8 areas eligible for MDA. For the simplicity, the implementation unit are denoted with the same name as the district. The 8th implementation unit was estimated at risk population of almost 101,000 people located in 7 governorates in Yemen. 5 of the implementation units in the Western Governorate of Yemen were co-endemic with onchocerciasis. This was no worry because we will apply or we will give the drugs that will also eliminate onchocerciasis, which is ivermectin. The highest rates of antigenemia were found, of course, in Scotra Island. We found in Scotra Island, in Hadibo and in Colombia, almost 40% and 20% prevalence of antigenemia. Where in the mainland of Yemen, the antigenemia prevalence was ranged from 2 to 10%. The mapping survey was evaluated by WHO consultant in 2001, and Yemen was included as lymphatic filariasis endemic country, meaning that there was consultants that approved the all over country identification of the implementation unit. And this consultant was also here in Egypt. My professor, Dr. Reda Ramzi, and Professor Maged Al-Satuhi were the consultants that reviewed the result of the mapping surveys in Yemen. Based on such evaluation, an additional ICT surveys or immunochromatographic test or rapid surveys were conducted in 34 other districts during 2003 and 2004 to try to figure out or to discover more units available for introducing the program, but no more NDA eligible units were identified. Now let's look at the 8 implementation units for our program that was discovered by the mapping and was confirmed as endemic areas for lymphatic filariasis. We can see here a big problem with Scotra Island. It's constituted the start of the story and the start of the case and the highest prevalence of cases as well. And we can find the other 8 units. There was 2 units in Taz. There was 1 unit in Hudaydah, there was in Zumur, there was 1 unit in Ib, 1 unit in Abiyan, and 1 unit in Shabwa Governorate. This table describes the population living in the 8 implementation units, as well as the prevalence of antigenemia in the 8 implementation units. We find, for example, in Socotra, we have 2 implementation units. We have Hadibo and Colombia, 40% and 21%. In Zomor, we find areas reaching from 1% to 14%. In Taz, we find 2 implementation units, 6.5% and 10%. In El Hudaydah, 2%, in Ib 1.3%, in Abiyan 3.2%, and in Shabwa or Osailan 6%. This table also represents for you the prevalence so that you can see the highly affected area was implementation unit 1 or the Scotra Island implementation unit. Then we started the program or started doing the program or implementation of the NDA program in Yemen. The NDA, as I said, was started with 2 drugs, ivermectin and albendazole. They were the cornerstone for lymphatic filariasis elimination in all implementation units. 5 NDA rounds were completed between the year 2002 and 2006. The first round of the NDA was conducted by the end of 2002 in all implementation units, except Osailan, which was due to security reasons delayed till the beginning of 2003. The target population, as I said, was almost 111,000 people, lived in almost 1,096 villages and small settlements. The yearly round of NDA was conducted based on house-to-house distribution by mobile teams of primary healthcare workers. The NDA campaign consisted of several steps in the following order. The first step of the campaign, we have to do training for the physician, for the nurses, for volunteers, for healthcare workers at the rural areas of the health units of the target areas. Why? We want to them to know what is the disease, how it is spread, what is the number of doses for each person according to his height, the number of persons that you will reach Each team will reach, for example, 100 persons per day. This was also as a package that we must do training before the start of the program. Training was focused, as I said, on drug distribution, including calculation for ivermectin doses suitable for different heights. Training was also provided on the use of local guidelines, filling in the forms to document of NDA coverage. Those going to the field must fill several forms for the NDA, and there is a special form for adverse reaction or adverse events from the drug. This has to be recorded also according to the WHO guidelines. The session were repeated annually about 3 months before the next NDA round. The second step in the NDA program was social mobilization. One of the key factors for success is how to reach the people and convince the people to take the drug, because the cornerstone for NDA success is to have above or equal 65% of the people accepting to take the drug. Because as we said, we want to do interruption of transmission. We want to cut the two cycles apart. So the National Lymphatic Filariasis Elimination Program used a variety of formal and informal social mobilization or health education channels to reach out at risk population with the message that the drug can be administered are safe and that MDA important and that it needs their support and continued commitment. We want to tell the public that your sharing and you taking the drug is doing a success not only to yourself, but to others and to your country. The activities consisted, for example, social mobilization activity consisted of meeting with the local village chiefs and religious leaders, distribution of pamphlets and posters, announcement of the campaign on the street and places like hospital, as well as short program on the radio to raise awareness and encourage community participation. Of course, as we did here in Egypt, of course, we reached lymphatic filariasis here also in Egypt 1 year before Yemen. We reached elimination, or we were certified as elimination in 2018, and Yemen reached the certification in 2019. As we said here in Egypt, we also go to imams and religious figures and role models and teachers. Target districts are also participate, and we want them to participate in the program to convince the people to take the drug and that it is useful for themselves and for others. A mobile team toured the rural areas and explained the importance of mass drug administration, or MDA. Public education and mobilization were also furthered in national and local newspaper and in television spots and interviews during the coverage or the mass drug administration program yearly. In 2003, the effectiveness, we want to now to know the program validation or the program coverage. The effectiveness of MDA on the microfilariasis infection rate and intensity was assessed about 6 or 12 months after MDA number 2. The same exercise was repeated after MDA number 4. Sick blood smear was collected around midnight from approximately 500 subjects above or equal 3 years of age, residing in sentinel sites and spot check sites in each endemic district. Sentinel site meaning that this is a survey is done in this site and I won't leave this site. Spot check sites are not covered each year. Were examined for the presence of microfilariasis. The assessment survey showed complete microfilariasis clearance in all areas of Yemen except in Hadibu and Colonsea in Socotra Island, where the microfilariasis prevalence was still 5.8% and 1.8% in 2004. The assessment survey were repeated in the 2 positive areas during 2005 up to 2011. The following figure shows the prevalence of the infection of lymphatic filariasis from 2003 up to 2011 in Socotra Island. We find that the prevalence dropped from 5.8% to 2.4, then again rise it to 3.7, then dropped to 1.4, then up to 0% in 2009. Excuse me. In vector control, as of the year 2000, mosquito control measures were implemented by the malaria control program, meaning that they started, the program started with collaboration with malaria control program. They wanted to get rid of the Anopheles, and by the way, the vector for the mosquito for lymphatic filariasis, they distributed in larvicidal spraying in 8 implementation units and indoor residual spraying of chemicals in 441 villages, and distribution of 449 impregnated nets. In 2005, however, Culex quifacitus was identified as the lymphatic filariasis vector, and so we have to do another strategies for lymphatic control for outdoor and indoor cesspits. This strategy was by the use of what we call expanded polystyrene beads. They started strategies by distribution of 2 mm expanded polystyrene beads or diesel fuel in 127 cesspits in Hadibo and surrounding village, population education and promotion to reduce or avoid mosquito bite, and distribution of long-lasting impregnated net. Such intervention, after we discovered the mosquito of concern, were very effective in reducing mosquito densities from by about 80%, and this reached statistical significance, meaning this is actually working after we did our strategies relative to the pre-intervention level, and the mosquito elimination lasted for almost 3 months, more than 3 months after we included those activities. Furthermore, mosquito infection rates was determined by the detection of Vachira bancrofti DNA by Ramsey et al. In 1997. It dropped from 0.73% in 2007 before the beads distribution up to 0% 3 months after supplementation of the MDA with application of the polystyrene beads. As we can see here in the figures, the beads were distributed to the houses, and even children can put this in the cesspits. This would perform a layer on the cesspits so that the mosquito will no longer be able to put their eggs or do multiplication in the pits, to decrease the number of mosquito by about around 80%. And this was published in an article called The Impact of Polystyrene Beds as Mosquito Control Measure to Supplement Lymphatic Filariasis Elimination Activities in Socotra Island in Yemen. Supplement the activities, meaning this is additional for how to increase the effectiveness of our program. But the main issue of the program, how to reach the people with the drugs to eliminate the disease. I find this article very interesting, of course. I got this slide for you to show that in Yemen, all mainland implementation units have met the WHO criteria for stopping mass drug administration after 5 rounds. However, in Socotra Island, these criteria were not met. This study was evaluated the efficacy of applying expanded polystyrene beads or EPBs on the Culex population and the effect on lymphatic filariasis transmission. Human and mosquito surveys were conducted in 40 randomly selected households in Hadibo, the capital of Socotra, before and after application of the beads. The beads intervention resulted in reduction of mosquito density of 80% and 64% reduction in microfilaria prevalence. The majority of the interviewed households, 98%, thought that these beads would considerably reduce the mosquito population. They were very happy because they suffered too long time from the mosquitoes and their annoyance. After the applications, they were very happy about the result. After the intervention, all collected pools tested negative, meaning for negative for DNA for Vachura bancrofti. Application of the bead is an effective supplement to MDA for achieving the goal of lymphatic filariasis elimination. Now let's look at the monitoring of the MDA, which is the third step, the monitoring and evaluation of the MDA. Monitoring of MDA implementation is a vital element of program management for assessing the success of MDA campaign by the WHO definition. Therefore, the elimination program monitors the MDA coverage and microfilariemia prevalence rates in selected sentinel sites and spot check sites. In addition, MDA side effects were monitored after the first MDA campaign that was implemented in the year 2000. Monitoring in terms of adverse events, during the first week after the first MDA campaign, a team actively examined 1,400 randomly selected treated people for side effects and serious adverse events. No serious adverse reaction were observed. However, in Scotland Island, 12% of the people reported mild and moderate adverse reaction like fever, headache, or myalgia, which is very normal for these two drugs, and they are all transient. In the mainland, the observed side effects were swelling of the legs and itching, and for areas co-endemic with onchocerciasis. Furthermore, a positive and good effect of MDA observed in the mainland was the passing of the intestinal worm, with decreased prevalence of Ascaris lumbricoides from 64% before the MDA to 3% after the applying of MDA1. There were fewer adverse reactions of MDA2. Now let's look at the monitoring of MDA coverage. We want to see how many of the people actually took the drug and they were compliant with our recommendation of taking the drugs. The MDA drug coverage rate reported by the drug distributors that reported the coverage of the 5 rounds implemented from 2002 to 2006 ranged from 77% to 86%, with an average of 81% of the total population of the implementation units and 90% of the eligible population to take the drug. To assess the MDA coverage, the elimination program conducted a survey after each round or surveyed coverage. We want to make sure that the report that comes from the field is typical or is identical to the surveys, so that the WHO or the WHO would be satisfied with the result of the elimination program. In 30 randomly selected houses in each district, household member present during the survey were interviewed with a questionnaire as per the WHO guidelines. For example, that during the third MDA campaign, 8 implementation units with a population of 1,073,000 were targeted, and assessed coverage was 82%. In general, the coverage rate in all areas were above the WHO recommendation of 65% of population at risk, and it almost reached the target of above 80% as set by the elimination or the National Yemeni Lymphatic Filariasis Elimination Program. As we can see here, what is the definition of the reported MDA coverage by the people coming from the field on drug administration, and what is the definition of surveyed MDA coverage, which is a proportion of the individual in household survey which have ingested the drug of the total individual residing in 30 houses surveyed in each implementation units. This is done after the MDA round has stopped to make verification of the reported MDA coverage. As we can see here in this graph, the reported coverage in blue bars and the surveyed coverage in red bars. As you can see, the prevalence is almost identical in the 8 implementation units. So now we are quite sure that the reported coverage and surveyed coverage are more or less the same. So we are now confident about the percentage of coverage is above 65% or reaching 80% and sometimes reaching 90% here, as we can see in Socotra Island. Now for the question, how to stop the MDA program, how to stop the rounds. As we can see, the National Lymphatic Filariasis Elimination Program followed the WHO guidelines for stopping the MDA. Such guidelines called for conducting MDA stopping surveys in implementation units. They have two conditions. You must have at least 5 effective rounds of MDA, and those 5 effective rounds have MDA coverage above or equal 65%. And the third condition, the microfilariemia prevalence or the diagnostic stage has decreased below 1% in sentinel and spot check sites. If you have those 3 criteria, you can safely now stop the MDA distribution program. Accordingly, the MDA stopping surveys were conducted in the 7 mainland islands or mainland in Yemen or mainland implementation units. Furthermore, the WHO guidelines called for conducting lot quality assurance survey using ICT in 300 children in 2 to 4 years and if all negative, lot quality assurance of 3,000 children aged 6 to 8 years, representing all communities, should be carried out. This is another confirmatory steps for the elimination. Indeed, all children 2 to 4 years and 3,000 children examined in the 7 implementation units in the mainland were uniformly or all were negative. Therefore, the MDA or mass drug administration rounds was stopped in 7 main islands in 2006, but continued in the problematic area of Socotra Island implementation unit. As we said before, this was a highly infected place. The prevalence was almost 40% in one of the implementation units in Socotra. So this had to go further beyond 2006. In 2011, actually the MDA round in Socotra reached up to 2011. A total of 531 subjects were examined for microfilariemia in sentinel site of Hadibo of Socotra, and all were microfilariemia negative in the year 2000. Consequently, the National Lymphatic Filariasis Elimination Program followed the WHO guidelines for stopping MDA and implemented transmission assessment survey, as I told you in the first figure, or test survey in Socotra Island. For test 1,389 school children 6 to 7 years were examined for antigenemia by the immunochromatographic test, and only 1 girl was positive for ICT. As the critical of was 16 children, Socotra Island passed the test survey and MDA was stopped. The test was done in 2011 to make sure that we reached our goal, below 1% microfilariemia, or all the test children were negative. If we reach the goal, we will stop the MDA round. Actually, we reached the goal and we stopped the MDA round in 2011. Full investigation of the ICT positive girl, the 1 girl that they found, and her family members also revealed that none of them were microfilariemia positive. However, treated with 2 doses of ivermectin plus albendazole in 2012. Now let's look at how we now document the elimination of lymphatic filariasis as a public health problem and to do the dossier for verification of the WHO. The reduction of levels of lymphatic filariasis infection endemic population to a threshold below 1% in microfilariemia or below 2% antigenemia, where transmission is likely no longer sustainable, meaning if we reach those 2 levels, or microfilariemia below 1% or antigenemia below 2%, we are now sure that the transmission cycle was interrupted and the recurrence is unlikely to occur. TESS is a survey designed to determine whether evaluation units or the at-risk population is less than 2 million people have lowered the prevalence to the target threshold. To pass the test is a very big study, and there was a PDF or a file for doing the test, and it is present on the net, and this is out of scope of my presentation. To pass the test, the number of positive children or 6 to 7 years should be less than a critical of values based on the sample size selected. indicating that the infection is below the elimination threshold. Infection must be maintained below this threshold level for at least 4 years after we stop MDA distribution, meaning that we must wait 4 years after doing the test, and then we do another test. This is what we call surveillance for or post-MDA surveillance. Post-MDA surveillance, meaning after we stop the MDA, we must now check the infection rates even after we stop the MDA to make sure that there is no recurrence of this disease in our implementation units. Included conducting test number 2 and test number 3 in 2013 and 2016 respectively. In addition, during 2012, the elimination program investigated approximately 60 night blood smear from hospitalized patients in Hadibo, a previously highly endemic area. All were microfilariemia negative. This was doing as a precautionary step. If we do sampling of the patients that are hospitalized to make sure that we are free as well, they took 69 blood smear samples and they were all negative in Hadibo. Post-MDA surveillance in 2013, a test was carried out in the mainland of Yemen, mainland implementation units, 7 years after the MDA was stopped, and in Socotra Island, this was only 2 years after the MDA was stopped. Note that test conduction is costly and the nation could not afford carrying it in the mainland island, in the mainland of Yemen for several years. For this test, considering the geographical and epidemiological feature, the implementation unit on the mainland in Taz, in Hudaida, Zomor, Ib, and Abiyan were combined in one evaluation units or EU units. And those in Socotra Governorate formed a second EU or evaluation unit, because we want to do a success for our main evaluation unit, and we also want to do success in our Socotra or highly starting prevalence rate. Note that the mainland implementation units are considered low risk areas, and Socotra Island was considered as high risk area based on the baseline prevalence and data in sentinel and spot check sites. Children 6 to 7 years were the target population, and the ICT card test filariasis donated by WHO was done to detect circulating filarial antigens. So in preparation for test 2, 3 Yemeni medical officers participated in the test training courses organized by the WHO, because regional office for the Eastern Mediterranean region in Cairo in 2012, and they supervised all the test activities, meaning we want to do an officer who know all the test activities from sample size, from selection, from the students, the schools that they were going to. There was training for 3 officers, and then they would supervise all the test activities. However, no training on the use of card test was required because the nation program technician had been using it for so many years. According to WHO program was used to choose sampling strategies and calculate sample size and sampling fraction and sampling interval and cut-off numbers. None of the 3,359 school children, almost 1,800 boys and 1,500 girls, tested in 62 schools, representing the 2 evaluation units, one in the mainland and one in Socotra, had a positive ICT result. Thus, the 2 evaluation units passed. We now give them the green card, and the test indicating that the lymphatic filariasis transmission has likely been eliminated in these areas. In 2016, the third and final test was conducted in the same 2 evaluation units. However, it was not done by the ICT card. The ICT card was now obsolete. They have another card or another technique called filariasis test strip or FTS. This is the improved version of the ICT card and was used in the same technique in 2016. None of the 3,527 school children, almost 2,000 boys and 1,400 girls, tested in the context of the final test had a positive FTS result or filariasis test strip result. as the critical cutoff value of this sample population was 16 positive cases, the two evaluations passed the test. These findings clearly demonstrate that the lymphatic filariasis had been likely to be eliminated as a public health problem. Why? Because we stopped the MDA round for many, many years, and still the result is negative, meaning that the problem is now no longer public health problem. And in all the implementation units as regard the guidelines. The post-validation surveillance, the National Lymphatic Filariasis Elimination Program is sustained surveillance after the WHO validation according to the guideline and relevant advice of the LF scientific community. Such activities were fully integrated with the National Leprosy Elimination Program. This included the morbidity management and disability prevention. After we stopped all the activities, we now want to make sure how to relieve the suffering of the people who have lymphedema or who have huge swelling of the legs or hydrocele, huge swelling of the scrotum. Now we want to do the basic benefit package for treating lymphedema as well as night blood surveys whenever possible. So far, no microfilariemia positive cases were detected. Other maintained activities include coordination of the integrated vector management in areas with high mosquito densities, continued coordination with authorities for better sanitation and development in areas at risk. In addition, the elimination program encouraged proposal for post-surveillance research, meaning we want students or public health students to make researches about post-surveillance in terms of lymphatic filariasis infection after we stopped or after we do the surveillance. Now let's look at what we did in terms of morbidity management and disability prevention. The activities were performed in leprosy clinic during 2000 up to 2019. This is why we call the neglected tropical diseases to be merged together to use all the facilities that we have to reach our patients. We want to reach the lymphatic filariasis patients in the leprosy clinics that is well maintained in all areas of Yemen. People with lymphedema have access to continuous disease management and prevention of progression to more advanced stage in the 22 governorates in Yemen. Leprosy clinic in 17 governorates provided the morbidity management to ensure sustainable access to basic care for each affected person. Healthcare workers in leprosy clinic were trained to care for patients with lymphedema and elephantiasis, guided by the WHO guidelines. In 2002, the elimination program prepared an Arabic booklet distributed free of charge to guide self-care of patients. The preparation of the booklet, you will find this booklet on the internet, was guided by information presented by Center of Disease Control and Prevention USA, which is called the New Hope for People with Lymphedema. The booklet illustrates simply morbidity management, including hygiene and skin care to prevent acute lymphangitis and proper wound care, exercise, elevation of the affected limb, and proper footwear. In addition, the elimination program provided treatment for the acute skin attacks with antibodies and secondary treatment, such as additional doses of ivermectin plus albendazole, miconazole, and fusidine cream. Miconazole cream is antifungal cream, and fusidine cream is antibacterial cream needed to treat the acute attacks of skin infection in patients with repeated multiple attacks of lymphedema. Also, potassium permanganate powder and doxycycline was tablets for 1 to 2 months was also distributed as in leprosy clinic. In terms of also disability prevention, some studies also documented the use of benzazine, benzyl, penicillin prescribed in some cases with other antibiotics for acute attacks. Locally made sandals are provided in the leprosy clinic. Sometimes the patient cannot wear normal shoes. They have huge legs or huge foot. So they made them sandals that were locally made, and they were distributed in leprosy hospital in TAS for some patients. And advice is given about the use of elastic socks Registers for the treatment of lymphedema were distributed in each leprosy clinic to of case and leprosy supervisor from the program headquarters in the clinic to ensure the quality of service in lymphedema in quarterly visits for service with those for leprosy. The interventions significantly reduce the frequency of acute attacks in patients to around 80%, as determined by the patient follow-up questionnaire. Also, there was hydrocele surgeries for patients who have hydrocele by the urologist in hospital and in the clinic and the clinics of the main cities, and any case of hydrocele reported to the leprosy clinic is referred to urologist for hospital for doing the surgery. The resources, some viewers would say how this program was very successful and how it reached all those activities. The resources and partnership was by the WHO, supported the entire process of elimination activities in Yemen financially and technically by providing the necessary drugs and necessary training. The WHO also provided technical support in form of visits, form of consultant who provided training in mapping in August 2000. Actually, most of them were Egyptians and they were very happy to give their experience and their knowledge to do the elimination of this lymphatic filariasis in our second country, Yemen. Evaluation of the ICT in January 2001, also provided by the consultant, training in sentinel and monitoring and taking blood smear in June 2003, determination of vectors in February to March 2005, and evaluation of the program in February 2010. The National Leprosy Elimination Program and its partners, the German Leprosy Relief Association and the Yemen Leprosy Elimination Society, supported the program with infrastructure. All of this consists of the resources and partnership. The National Lymphatic Elimination Filariasis has now reached its final goal in 2016 to the test in spite of the challenges of the war situation. Approximately 8 years after MDA was stopped in 7 implementation units and 4 years after MDA was stopped in 1 implementation unit, which is Kotra Island. All of the evaluation unit passed the test, indicating that the program has fulfilled the WHO requirement for elimination of lymphatic filariasis as a public health problem. Consequently, the elimination program prepared a country dossier according to WHO guidelines, submitted to the WHO regional office for the Eastern Mediterranean region in 2018. This accidentally was in Egypt, in Cairo, the regional office for the Eastern Mediterranean region. The dossier was submitted in 2018, and of course, the final chapter of the dossier submission for WHO, based on the data presented and findings, the Yemeni elimination program on behalf of the Ministry of Population and Health, the lymphatic filariasis elimination dossier for submission for the WHO EMRO in 2018 as evidence for the successful elimination of LF as a public health problem. The dossier was reviewed and validated by the Regional Dossier Review Group of the WHO EMRO and an external review panel. In 2019, the WHO headquarters officially acknowledged that Yemen met all the criteria for achieving the elimination of lymphatic filariasis as a public health problem. Despite the challenges, despite the suffering, Yemen eliminated lymphatic filariasis as the second EMRO country after Egypt. This was reported by WHO in 2020 and by Ramzi et al. In 2019. And of course, you can find the website in neglected tropical disease website over the WHO that this is as I call the final successful story and the final certificate for validation is that of 2019, the Yemen is officially eliminated as lymphatic filariasis as a public health problem, and is the second country after Egypt in the WHO Eastern Mediterranean region to achieve this criteria. Of course, this program has been running for almost 2 decades in Yemen, and Yemen deserved the successful annotation or the successful recognition by the WHO, and I congratulate Yemen for elimination of a lymphatic filariasis program that was collaborated from also Egyptian professors and Egyptian scientists that demonstrated all steps in the elimination program. And I thank you for your listening and your participation. Thank you very much. Dr. Khalid.
Very fantastic talk. I would like really to thank yourself first for telling us such a pleasant story, and also to thank all the people involved in such a very successful project and all the sponsors as well. It's not easy to eradicate any sort of infectious disease like lymphatic filariasis. So it's absolutely amazing. I'm so pleasant to hear this story today. And there are some questions here from some of our colleagues.
Yes.
Are you able to see the questions, Professor?
No. How can we limit the?
Right.
I cannot see the questions. No.
I can read some of these. There are a number of questions. I guess we'll select some of these questions. There is one of our colleagues is asking, my dear Professor, what's the important thing that we can use from elimination of other endemic infections in Yemen? So in other words, a translating lesson that we also can manage to eliminate other diseases, infectious diseases in Yemen.
Actually, this is a very good question. Elimination of other endemic disease or other neglected disease has to be on the guidelines of the WHO. Each neglected tropical disease has different criteria and different reservoir and different mosquitoes or vectors. So I cannot apply the same steps that we did in our lymphatic filariasis elimination in another disease, except that we follow the guidelines of the WHO. Lymphatic filariasis has also a very unique criteria that I showed in the first graph, that there is also only man-to-man transmission through the vectors, meaning that interruption of the transmission cycle has led to the success of elimination. So I cannot answer all neglected tropical diseases. This has to be followed one by one.
Great. There's actually a question here running at the back of my mind as a physician also and a clinical scientist. And I can see here one of our colleagues also shares the same idea with me. It's all about the risk of recurrence of this disease. How do you like to comment on that, please?
Actually, this is what I've been saying from the surveillance and post-MDA surveillance. All of this, as you can see, we have done activities after stopping the program by 7 years to do a surveillance, meaning we want to make sure that the disease will not resurge again in the 8 implementation units. After we did test 1, test 2, or transmission assessment survey for children in 6 to 7 years in school, we are now sure that disease will not recur again. This will no longer be an issue, or will be no longer of to put in your mind that there will be a turn again. This is all the 2 decades. One decade was almost in MDA coverage, and the other 9 years or 7 years was making sure that this will not recur again.
Great, great. On my behalf and the conference panel and all our colleagues here, I would like again to thank you so much for such a very
You're welcome.
teachingful and educative presentation. Thank you again.
Thank you very much. Thank you.
Right. Okay, so at this moment we will close the session and we'll meet again in about 40 minutes from now for the third session. Thank you everybody for listening and contributing, and we hope to see you again in 40 minutes. Thank you again. Cheers. Bye.
Okay, welcome back everybody to the first set of presentations for the afternoon. So just a quick housekeeping reminder, if anybody is in the attendee section who's due to give a presentation later on, please raise your hand so that we know to promote you to speaker status. But first of all, I would like to introduce Dr. Frederik Federspiel. Dr. Federspiel is working as a clinician in Denmark and has done global health work in various countries, including Nepal, Uganda, and Cameroon. He works and manages a small international development NGO known as the People's Fund for Global Health and Development, mainly focused in the Côte d'Ivoire. And he is also a research student at the London School of Hygiene and Tropical Medicine. So without further ado, Frederik, would you like to get started with your presentation? Thank you for joining us.
Of course. Thank you very much. And thank you for the kind presentation. Do you hear me all right?
Loud and clear. Please go on ahead.
All right. So I just thought, do I share my screen like this? Do you see my screen?
I'm just waiting for it to come up.
So share screen.
Yep.
Yeah. So
it's not come up yet.
Okay, this one. You see it now?
Yes, there we are, ready to get started.
All right. So yeah, thanks everyone. As Dr. Wong just said, I'm Frederik Federspiel. I'm a PhD candidate at the London School of Hygiene and Tropical Medicine and a pediatric registrar in Denmark. The title of my talk is The Cholera Outbreak in Yemen, Lessons Learned and Way Forward. I did this work in 2017 and 18 with Dr. Ali at the Johns Hopkins University in the States. It was published in the BMC Public Health in 2018. Now, first of all, I'd just like to make a couple disclosures and express my deepest respect to all of you in Yemen listening, working under impossible circumstances, doing tremendously important work. It's a true honor to be presenting to you, so thank you. And I think it's important that you all know that I have never been to Yemen. I did this work entirely as academic research done outside the country with no firsthand experience of the context in Yemen. So I think it's important you keep that in mind as a sort of caveat for my talk. But that said, here's what I have to say. So the background for the study was first a bit of epi. The cholera outbreak in Yemen is, can I just put this down here? Is and was the largest and fastest spreading cholera outbreak recorded since the WHO began recording cholera outbreaks in 1949. There's been more than 2.5 million suspected cases. 1 in 4 cases have been children under 5, approximately 4,000 deaths, with I must say, impressively low case fatality rate of 0.16%. So well done. So there was a massive first wave with about 1 million cases in 2017, and then sort of a second and third, fourth, fifth waves throughout 2018 and 19, and then the epidemic seemed to slowly burn out during 2020. The root causes of this, the key causes of the epidemic, was of course the conflict, but Yemen was already dealt with malnutrition, which exploded during the conflict, and during the conflict there was complete breakdown of wash and infrastructure, and the external support and all the humanitarian responses were greatly impaired. Health facilities crumbled, prices increased. This is stuff you're all aware of, but this is of course all the different things that came together as a perfect storm for this epidemic to happen. Now, the aim of this study was not to the aim of this study was to see if there was any lessons that could be learned for the global humanitarian and public health community from the humanitarian response to the cholera epidemic in Yemen. So not to criticize the international humanitarian response, because that has of course been truly difficult, but to see if there's anything that could be learned for future outbreaks in other endemic settings that experience some similar circumstances to prevent another outbreak of this magnitude from happening. The methods we used was that we reviewed the activities of the major international health organizations involved in the humanitarian response in Yemen. We did this in 2017. We looked at their websites and reports. We looked at English language literature, published from 2015 to May 2018, which was very little existing literature. The results of the study was that we found that the WHO had focused their attention on sustaining the functionality of health facilities. They had established cholera treatment centers. They had trained health workers, operated health and nutrition mobile teams, delivered child nutrition interventions, expanded disease surveillance capacity, and distributed fuel, IV fluids, cholera kits, cholera cots, and ambulances. UNICEF had provided safe water, delivered medicines, ORS, IV fluids, diarrhea kits, and served as the WASH cluster lead. They ran cholera awareness campaigns across Yemen using community hygiene promoters. The IRC focused their attention on delivering health, nutrition, WASH services, drugs, medical supplies. They trained health staff on cholera treatment. They advocated for a direct humanitarian air service and for peace. They deployed mobile health teams, established community health volunteer networks for referral of malnourished children. The ICSC sent medical supplies, including IV fluids, ORS, antibiotics, and chlorine tablets, supported cholera treatment facilities, and dispatched engineers to restore the water supply systems. And finally, MSF, the last major organization in the health area, working in Yemen, treated patients in cholera treatment centers and oral rehydration points. They, at the time the review was conducted, they were planning to conduct outreach activities, including chlorination of infected water sources, distribution of hygiene kits, and awareness raising via radio stations and mosques. So in summary, that was a lot of detail, but in summary, these activities from the international humanitarian health organizations, this is of course not an exhaustive list, and of course all these organizations did a bunch of other work, but this was what we sort of gathered was their emphasis, their main areas of focus. They delivered a lot of new health services, supported the existing health system, delivered healthcare infrastructure, water and hygiene interventions. They trained staff, conducted a lot of epidemiological activities. There was management work, there was awareness work, and advocacy work. So our analysis from going over this was that there was also some things that were not done. And what we found was that no one did oral cholera vaccination. It wasn't done until 16 months into the epidemic, August 2018. As you can see, that's after the first wave, and more than 1 million cases had already occurred at that point. There were concerns by aid agencies that vaccination would be futile, that the epidemic was too large and impossible to control. They cited, obviously, security issues, logistical challenges, and this was undoubtedly incredibly challenging at the time. There were so we also found that sanitation work was not an area of emphasis either. None of the investigative organizations reported any specific sanitation interventions. Now, there were a series of financing shortfalls that led up to the epidemic in 2017. First of all, in 2015, the WHO experienced a funding gap of more than 80% of their activities in the Yemen health cluster. In 2016, 47% of the UN response plan was funded, leaving a shortfall of almost $1 billion of what they intended to do. Then there was a high-level pledging event in 2017 where only $1 billion was raised, and the target for that pledging event was $2 billion. And there was an additional funding appeal at that event to get a $250 million specifically for combating cholera, and they only got a fifth of what was intended. So there was this series of failures of the international community, the donors, to support these organizations in their work in combating cholera in Yemen. But our argument in the piece is that these issues with security and logistical challenges are, of course, completely true and very, very valid. But evidently, it has been possible to carry out major humanitarian interventions and to manage cases, helping keep the case fatality rate at an impressive 0.21%, which was the number in 2018. And there was approximately 2 years of humanitarian presence preceding the outbreak with all these organizations present in Yemen. So what we sort of concluded in this piece was that there appeared to have been a focus on more reactive cholera management and control rather than prevention of a full-scale epidemic by, for instance, mass vaccination and sanitation work. So as I said, the intention was to see if there's anything that could be gathered from this that could be learned for the international humanitarian health community. Improved lab and surveillance capacity in cholera endemic countries would be one way to be able to declare outbreaks faster. This is not only us that are advocating for this, but other authors as well. A simplification of the mechanisms for access to the ICG stockpile of oral cholera vaccines. So the ICG stockpile is simply it's housed under the WHO, and it's the international body that manages this big stockpile of vaccines. If this were simplified, it could lead to more timely deployment of vaccines. Now, this stockpile has been greatly expanded. And in 2020, many more doses were shipped than previously. But as you can see on these numbers, more than 10 million doses were requested and only less than half of that were shipped. So we're still not there yet by the looks of it. Also, single dose killed oral cholera strategy is possible when double dose vaccination is too challenging. There's a lower efficacy, but it is possibly when it's deemed simply impossible to vaccinate twice. Alternatively, there is also a single dose live attenuated oral cholera vaccine, which has a higher efficacy, but it's more expensive. The Sphere handbook, which is sort of the handbook for humanitarian emergencies for the health sector, has been updated to recommend mass OCV, so this is a welcome change. And finally, in the piece, we also advocated for better decision support tools for when to deploy OCVs preemptively. What would have helped these organizations push the button in the 2 years preceding the outbreak and say, okay, we need to do something preemptively. On the sanitation side, I'll leave you with a question. This is a question we raise in the piece. And I don't expect for you to be able to answer this question, but I think it's something that's important to discuss and ponder if you work in this field. Should international humanitarian health organizations increase their focus on addressing the environmental determinants of health rather than managing the cases that they generate? That's it from me. Thank you.
Thank you very much, Dr. Federspiel. So we have plenty of time for discussion at the moment. Yeah. So if any colleagues in Yemen would like to share any real life experiences or their thoughts on managing the situation on the ground in Yemen, please feel free to share your experience with us. Well, I had a question I'd like to pose based on the contents of your talk. Do you think lessons will be learned for the future if and when this happens again for the next cholera outbreak, whether in Yemen or elsewhere?
I think, sadly, the international COVID response has been a very illustrative example of how the international community still operates in 2020 and 2021. It appears to be a scramble reactively after the fact, where the winner takes it all. The wealthiest countries grab as many vaccines as they can. International coordination is very much lacking, and so on. So it appears that these lessons have, perhaps in the field, in the era of COVID, not necessarily been learned yet. But you could hope that for similar circumstances in other countries where cholera is endemic, because there's a major difference that this vaccine was already there. It is sitting there on the shelf. So perhaps after COVID, countries will learn to really appreciate the value of preventive vaccination, preemptive vaccination. Maybe with Yemen plus COVID, the international community will learn.
Sadly, I think I completely agree with your viewpoints. I think you make very valid arguments in every sense. Perhaps one day we can hope for a better shared, more collaborative effort across the globe when it comes to managing outbreaks and larger scale pandemics. Okay, so well, thank you very much for your talk, Dr. Federspiel.
You're welcome.
I think a couple of our next few participants have unfortunately had computer-related problems and so won't be able to present their talks. That said, a couple of our other presenters are available on the chat now, so we're just waiting to see if they're ready to get started a little bit ahead of schedule.
Okay.
So our next speaker should be Dr. Fatima Samir, a general practitioner at the Ibn Sina General Hospital Authority. Dr. Samir, are you available?
Yes, here.
Excellent, welcome. So I believe you've got a talk lined up for us on outbreaks of dengue fever. Do you think you're ready to get started?
What? Shall we start now?
Yes,
Can
please.
I share my screen?
Please go ahead. The floor is yours.
Yes.
That's looking great. We can all see your slides now.
Yes. Assalamu alaikum. Welcome, everybody. Thank you for this opportunity to talk about neglected infectious disease in my country. I am Fatima Samir Bilhamar. My project about outbreak investigation of dengue fever in Ghail Bawazir district, Hadramaut, Yemen, in March of this year. Dengue fever is tropical viral infection which is spread by Aedes aegypti mosquito bites. Its incubation period from 3 to 14 days, usually takes 7 days. Main symptoms include fever, joint pain, pain behind eye, severe headache, muscular pain, and skin rash. Actually, there is no different or definitive treatment for dengue fever. We just use symptomatic treatment. Globally, around 3 billion people live in 100 dengue endemic countries in Asia, Pacific, Americas, Caribbean. Each year, around 100 million infections occur in the world. 500,000 dengue hemorrhagic fever. 22,000 deaths occurs due to dengue-related illness, mostly in children. And this map clarify red color, Yemen represented in red color, which means complete presence of infection. That is according to evidence consensus. My country is endemic in all coastal, dengue fever endemic in all coastal areas. Since 18 years, several outbreaks occurred. The first confirmed was in Shabwa. Al-Hudaydah, Ta'az, Hadramaut, Shabwa, and Al-Mahra represent the major burden of disease. In the last 10 years, Yemen suffered from waves yearly, especially in Ghail Bawazir. Ghail Bawazir is one of Hadramaut Governorate districts located east of Yemen, estimated population 80,614, which constitute 10% of Hadramaut population. Dengue fever became yearly visitor in the last 10 years. Actually, with the spread of COVID-19, many cases of dengue fever appeared records of hospital and health centers. That is why we conduct this work to assess the situation of dengue fever in our district. Our objective is to confirm the outbreak on Ghail Bawazir district, to identify the source of outbreak as possible, to develop the recommendation, assess and control and prevention, efforts. We use this method, collect reported cases in surveillance, hospital, private and non-private health centers. Data were entered in Excel sheet program and then analyzed by using case definition of WHO of Yemen Ministry of Public Health, Yemen EDOPS. Our result is the total number of reported cases were 610. About 18 cases from areas not investigated, so we didn't put it in analyzed data. The number equal 592. All these cases reported just in one month, from 10 to 14 epidemiological week. District attack rate equal 8 per 1,000. 11% blood samples were collected. 8% were positive for dengue rapid test, and these confirmed also by ELISA enzyme-linked immunosorbent assay in National Center of Public Health Laboratories at Al Mukalla. Peak of epi curve at 13. We see here 13 week has the highest of cases number, but 14 week has the lowest cases number. That could explain it by at the 13 week many of foggy campaigns have been reported in many areas of district. This is by gender. Male has the highest cases number more than female. That could be male, usually outdoor for social workers and other activity. By age groups, from 10 to 30 years have the highest cases of number. Also, in this by age group and gender, we see female has the lowest cases number. That could explain it by female. Usually in my country, they wearing long dress called ibaya, and they could protect them from mosquito bites. We calculate attack rate. We find here Al Ghail city has the highest cases number, but in an unexpected way, An-Nagaa city has the highest attack rate. That could explain it by An-Nagaa city has a large land agriculture in which there is water for irrigation or even stagnant water that make suitable environmental condition for vector breeding. Also, we see here Shuhair has the lowest cases number, that because many fog spray campaigns occurs in the city. This is by common signs and symptoms. All clinical picture from fever, headache, joint pain, muscular pain, and retroorbital pain included in almost of cases, except rash. It represented just in 11% of cases. Conclusion, outbreak on Ghail Bawazir district was confirmed, 11 positive for both IgM, IgG with highly endemic area. The age group is from 10 to 19 and from 20 to 29 is highest, made due to, as I said, working age, more social activities, player more time outdoor, or work in block factory. Less attack rate at Shuhair compared to An-Nagaa and Al Ghail city may relate to vector phagocytic spray campaign that slightly decrease the cases number, but infection is still occurring. The medium for vector breeding is very available. Most people save water in open containers we called khazanat al-miyah. That is for 10 days, especially in block factory. health education is very weak, no brochures, newspaper. Also, there is no awareness in social, using in social media. Our recommendation to increasing the community awareness to fight and eliminate breeding sites through safe water in clean, covered container, closed containers in houses, also in block factories. Empty and cleaning of water pools, providing health education leaflets and posters, also raising awareness, especially in by using social media. The next one, vector control campaign by fogging insecticide spraying with residual effect, mosquito nets distribution. And these two goals, to reach to these two goals, we need to multi-sector cooperation between many departments for vector control, between Ministry of Public Health Population and Ministry of Public Works and Roads, Ministry of Culture and Media, Ministry of Interior Affairs, also Ministry of Education. Many thanks for your listening.
Excellent. Thank you for presenting that, Dr. Fatima Samir. An interesting snapshot of quite a major dengue outbreak over the course of a prolonged period. While we're waiting for some questions to come in, we've got one audience member who's raised their hand. We haven't got a name for the individual, but did you have a question you would like to ask? No, the hand's gone down. Well, something I'd be quite interested to know, were there any deaths reported in the cohorts that you studied?
Can you ask again, please?
Of course. Did any of the patients that you identified in your study, did any of them die as a result of the dengue fever? Were there any fatalities from it?
You ask about mortality of dengue fever in
Yes.
my country.
Yes.
Actually, when I work for this study, there is no report of mortality. Maybe some mortality occur in my country, but there is no investigation to know the cause of death. I hope the idea, you got the idea from.
Yes. Thank you for answering that. It's while dengue certainly isn't a. Okay.
Yes.
While dengue certainly isn't linked with a high mortality in most cases, it certainly can be quite debilitating, especially when it's younger people and a young workforce who are most prone to getting it, as you've indicated. Fine. Well, thank you very much.
Thank you, sir.
All right, then. I think our next candidate our next speaker is Dr. Ma'in Abdul Jalil. Let me just. We're doing our talk slightly out of order, but Dr. Abdul Jalil is a doctor within the Yemen Field Epidemiology Training Program, and I believe he has a talk lined up for us on malaria. And thank you for accommodating us and appearing outside of our planned schedule to make up for the absences. Please. Excellent. We can see your slides on screen, Dr. Abdul Jalil, but do you want to just test your microphone? I can't hear anything at the moment. I'm afraid I think we're struggling to hear you, Dr. Oh, wait, hold on.
Hello. Hello.
There we are. Excellent. We can hear you now.
Sorry
Please
for
go on ahead.
this. Sorry for this. Can I share my slide now?
Yes, please go ahead.
Okay.
Okay, we can see that. Please go right on ahead. Thank you for joining us.
Hello. Good morning, good afternoon, and good evening, everybody here. I cannot express my happiness to be given this opportunity to present in this informative and interesting conference. My presentation is talking about malaria surveillance data analysis 2018-2019, Yemen 2020. First, I want to talking a little bit about malaria situations globally in our region and of course in our country. Globally, there were an estimated 222 million cases in 87 endemic countries, declining in 2019, declining from 238 million cases in 2000. At technical globally malarial strategy 2016-2013, at baseline of the 2015, there are an estimated 218 million cases. About the malaria death have reduced steadily from 736,000 in 2000 to 409,000 in 2019. The malaria situations in the Eastern Mediterranean region, malarial cases have reduced by 26% from 7 million cases in 2000 to 5 million cases in 2019. And the malarial deaths have reduced steadily from 2000 in 2000 to 10,100 in 2019. In the region, the Sudan is the leading country of the malarial cases in about approximately 46%, followed by Yemen. In Yemen, about 65% to 68% live under the risk of population live under the risk of the malaria. In this slide, the National Malarial Control Program was established in 2000 with the start of the initiative of the rollback malaria in Yemen, and the program performed many activities through many strategies, and the last one, the technical strategy 2020-2024, and it's composites of 8 core components, and these activities and strategy to achieve the goals of the programs. The malaria information system was stopped by the end of 2016, and this as a result the withdrawal of the global fund support. So, to overcome the difficulty of the data collections, National Malaria Program Control integrated or cooperated with the EDIO's electronic integrated system since 2018. In this figure, we show the data flow as it starts with the focal point in the health facilities, reported the malarial cases to the district level, then governorate level, after that to the central level in the EDIOs. And the governorate level, district level play role in the reviewing, verifying, and approving the data at the end of the year. After that, the central EDIOs exports the data to the National Malarial Control Program, and thus analysis and display the data by Microsoft Power API in the dashboard, and this is the websites of the data analysis and available for everyone. The objective of this analysis is to describe epidemiology and the trend of malaria by time, person, place, and identify high-risk group who are the children under 5 years and pregnant women during 2018-2019. About the methodology, descriptive analysis was carried during October to November 2020, and the data for the 2018-2019 obtained as a soft copy from National Malarial Control Program, and this data contains many variables such as the type of the species Plasmodium and the type of the diagnostic, either RDT or microscopy, suspected, probable, admitted, and death cases. And the analysis of the data using Microsoft Excel 2013 presented by time, person, and place, calculation of the rates and use of the tables and graphs will be used. Here we have three levels of the case definitions. We start with the suspected malaria. Patient INS suspected by a health worker to be due to malaria. The criteria include fever or history of fever, presumed malaria, any suspected malaria case treated with anti-malarial drug without lab diagnosis or treated even being malaria negative by lab. Confirmed malarial cases, suspected cases of malaria in which malarial parasite demonstrated by microscopy or RDT. Now I want to move to the results. In this table, we show the incidence rate of confirmed malarial cases increased, starts from 489 per 100,000 in 2018 to 515 per 100,000 in 2018. And this agree with the results of the analysis in the Ethiopia, but disagree with the analysis with results of the analysis in Yemen in the same country in 2015, and this may be due to the armed conflicts and its consequence of the deteriorations health system, humanitarian crisis, and internal displacement. In this figure, we show the case fatality rate of the confirmed malarial cases decreased. In 2019, it was 3.2 as compared with 13.8 in 2019, and this may be due to efforts in regarding to the case management, such as training the health worker about the anti-malarial update anti-malarial drug policies and standardized guidelines for the case management. What we are shown in this figure, in the term of the seasonality distributions of the confirmed malarial cases, the major transmission starts from October until to the April, and the month peak was in April. It was by 15.8% in 2018 as compared with 10.4% in 2019. This consists with the study in Yemen, but inconsists with study in Ethiopia and Pakistan. This as a result of the three main climatic factors which affect the malaria transmission, which are humidity, rainfall, temperature, which are different in a different time in the years, and also the stagnated of formations of the stagnated water give suitable conditions for the mosquito britings. This figure, we show the proportions of the confirmed malarial cases, and of course the microscopy is more than the RDTs. In this figure, we show the slide positivity rate decrease in 2019 as compared with in 2018. The slide positivity rate decreased from 21% in 2018 to 14% in 2019, and the microscopy positivity rate decreased from 14% in 2018 to 12% in 2019. And this reduction may not real as a result of the poor quality staining, poor reagents, limited provisions of the training in a term of the quality control and quality assurance, different skills in microscopic diagnostic among laboratory technicians, and also level of the parasitemia. Now in this table, we show the most predominant common species was Plasmodium falciparum by 99% in both years, and this agree with the documented pattern of Plasmodium species in Yemen, which was Plasmodium falciparum and belongs to the Afrotropical type. In this table, we show the admitted cases, which indicated to severe malarial increased in 2019 as compared with 2018. Here we show the males is more regarding to the sex, the male is more effective than the females, and this agree with many studies in many countries in the world. This is maybe due to the traditional culture of the Islamic countries where the woman prone to wear clothes cover all her bodies, and the man prone to wear clothes expose their legs and hands for the mosquito bitings, and also the activity of the males is outside of the home, and this coincides with the mosquito biting by the dawn and dusks. Also, the female mainly restricted to the home activities. This table tells us about the situations of the high-risk group, who are children under 5 years and pregnant women. And we say here the positivity rate decreased in 2019 as compared with the 2018, and this as the huge interventions as in these 2 years, approximately 1 million and 900,000 of bed net distributed for this high-risk group and also for all populations, 1 bed net for 2 persons. Now, this is the last slide in the results. We show Hudaida governorate had the highest incidence rates in both 2 years, followed by Hagga, and this as a result of the location of the governorate to the coastal plains. Conclusions slightly increase in the incidence rate of the malarial cases in 2019. Males were more affected than the females. The peak of the malarial trends was in October to April. Plasmodium falciparum was found as the predominant malarial parasites. Noticeable reduction was observed in the case fatality rate in 2019. Slight positivity rate decrease in both high-risk groups through 2 years. Tahama region has the highest incidence rate of the confirmed malarial cases. We finalize with the recommendation: strengthening surveillance with appropriate season-based net use is required, especially during malarial transmission peaks. Health educations to increase community awareness. Control activity should be continued and scale up. Thank you very much for giving me this opportunity and for your listening. And also, I want to thank all the doctors and the programs in the National Malarial Program Control and the doctors and staffs in the Yemen Field Epidemiology Training Program, as I am a resident in the 5th cohort Yemen Field Epidemiology Training Program. And this is, and I also repeat my thanks. Thank you very much.
Great stuff. Thank you very much, Dr. Abdul Khalil, for your presentation. The floor is open for any questions for you now, if anybody wishes to type anything into the chat. But while we're waiting for that, what are your thoughts on the future? Do you expect the trends in terms of case fatality ratios and the numbers of cases identified to improve in the coming years? Or do you think there'll be likely to be major barriers to that in the immediate future?
I think this is depends on the interventions and the controls activity will be done by the programs. And
Yes.
we live in a humanitarian crisis and armed conflicts. There are many activity in regarding to distributed bed nets and insecticidal spraying, and this may not play a role in decreasing the case fatality rate and malaria cases. We hope systems the epidemiology of the malaria and keep it from go back and worsens to the bad situations.
Yes. Well, fingers crossed as the situation improves, we'll hear better news from both the malaria and the dengue fronts. I suppose when it comes down to vector control, hopefully that will improve things in both areas. All right, then. So thank you again, Dr. Abdul-Ghali.
Thank you very much. Thank you.
All right. Moving on, we have a last-minute addition from Professor Mohammed Sadiq Al-Awar, who's going to be speaking to us about knowledge, attitudes, anxiety, and preventative behaviors towards COVID-19 amongst healthcare providers. Professor Al-Awar, are you there? Excellent. Thank you very much for stepping in at the last moment for the benefit of our program.
Okay.
So, without any further ado, I'll hand things over to you. Please go ahead.
Okay.
Yep, we're ready for you to share your slides at your discretion, Professor.
I share now. Not ready here. My PDF.
We can see your video. We're just waiting for your slides to come up.
Without BBT, PowerPoint. صورتي واضحة عنده. Start.
Yes, please go ahead whenever you're ready.
Okay. Knowledge, attitude, anxiety, and preventive behaviors toward COVID-19 among healthcare providers in Yemeni online cross-sectional survey. Introduction, background. Background. Start.
Yeah, you can start, but I'm afraid we can't see any of your slides.
I cheer, but not. The growing rapid incidence to coronavirus COVID-19 pandemic globally continues to associated with considerable degree of fear, anxiety, and panic among the community, especially for healthcare providers, seen as the most vulnerable group at risk of contracting this new SARS-CoV-2 COVID-19 infections. In order to protect and enhance the capacity of healthcare providers to perform their role in responding to COVID-19, healthcare authorities need to help their levels of stress and anxiety and improve their knowledge, attitude, and practice toward COVID-19 to ensure their compliance with infections controls. Aims of the study. This study aims to assess the knowledge, attitude, fear, and anxiety, as well as the preventive behaviors of healthcare providers toward COVID-19. Methods, study area, study design, and study period. Descriptive web-based cross-sectional survey was conducted among Yemeni healthcare providers between 22 April 2020 and 26 April 2020. All healthcare providers who provided direct healthcare service to patients were invited to participate in the study. Methods, study instrument. The questionnaire developing and used in this study was adapted from previously published study based on the authors. The questionnaire considerable 58 items that suit to the collect information on the responding's knowledge, attitude, anxiety, and preventive behaviors toward COVID-19. The questionnaire comprised of 5 parts. Part 1, the socio-demographic characters such sex, age, occupation, education levels, years, or working experience, and sources of COVID-19 related knowledge. Part 2, responding knowledge. Part 3, responding attitude. Part 5, including questionnaire on the responding behavior, preventive behaviors. Data collection. At the time of the study, due to the outbreak of COVID-19 and the specific preventive precautions and measures recommended by the Ministry of Health and Population in Yemen. An electronic web-based self-reported questionnaire was designed to comply with the recommendation. The internet link was distributed to the healthcare providers via email. Data analysis. The statistical package for social science version 22 was used in the administration and analysis of collected data. Descriptive analysis using mean values and standard definition of communities variable and the count and percentage for the dichromatic and category variable were used in results. First, healthcare providers demographic characters: 38 female and 62 male. Age 13 22 30 67 percentage. 31 to 14 25 percentage. Also occupation physician more 22.5 after pharmacy 70 also nurses laboratory. Education levels baccalaureus 73 and diploma 14 percentage. Experience years 88 more than source of COVID-19 data, social media and news media. Healthcare providers levels of knowledge regarding the COVID-19 pandemic. Adequate knowledge was 69 and moderate knowledge was 28. Inadequate knowledge was 0.16 percentage. Healthcare providers' attitude toward the COVID-19 pandemic. A positive attitude was 18.5 and negative attitude 40 percentage. Healthcare providers attitude toward the COVID-19 pandemic. Moderate anxiety was 51. High anxiety 27, while low anxiety was 21.30. Healthcare providers self-reported preventive behavioral toward the COVID-19 pandemic. High performance 18.7, while low 12 percentage. Association between the responding socio-demographic characters and their knowledge, attitude, anxiety, and preventive behaviors shown in the table. Conclusion: the results of the study have demonstrated that the majority of healthcare providers in Yemen had acquired and adequate level of knowledge of COVID-19. Their levels of knowledge can training stations that require wearing N95 masks and the possibility of using current antiviral drugs and antibiotics as the first line of treatment for COVID-19 could be improved through training and other programs. The moderate anxiety levels as reflected in this study would and reportedly increased particularly in the preventive core of the outbreak of COVID-19 elevated, and the stations become much worse. Therefore, implementing preventive measures and regulation strategies to control the emotional state among healthcare providers and recommended. In addition, organizations such as WHO and the Ministry of Public Health and Population in Yemen must continue to provide update information regarding COVID-19 to warrant future control corona or COVID-19. Then, thank you very much.
Brilliant. Thank you for presenting that paper, Professor Al-Awar, and for stepping in at the last moment. Some interesting conclusions and a real testament to the resilience and the spirit and professionalism of you and your colleagues in the healthcare sector in Yemen, despite the circumstances you're faced with day in, day out. Are there any questions from the attendees for the professor? Now, one thing I would like to ask, Professor, if I may. So your study was conducted in April last year. So just over 1 year later now, do you think things will have changed much amongst the healthcare profession. If you ask the same questions now, a year later in the pandemic, do you think attitudes will have changed much? I think let me just unmute you. Okay, we've just unmuted your microphone, Professor. Okay. All right. Well, thank you to Professor Sadiq anyway for his valuable contribution. All right then. Now, next in line, our program is getting a little bit out of sync now at the moment. Our next speaker also appears to have been unable to make it because of internet issues. However, I believe we have a video recording of one of the later speakers from Dr. Magdi Saif Al-Dari. We'll just see if we can get that video to work.
Hi everybody, I'm beginning Eid Fitr Mubarak for all, and I want to thank the family of this conference to give me the chance to present my topic here, and also great thank to our family, Yemen FETB family, for support us. My presentation today is talk about measles outbreak in a Dom village, Al Marawa district in Al Hodeidah Governorate from Jan to August 2020. That's prepared by Magdi Saif Al-Dari, trainee field Yemen epidemiology training program, and Abdul Qawi Kasra, graduated Yemen FETB, and Yahya Al-Faqih, surveillance officer in Al Hodeidah Governorate, and Dr. Muhammad Al-Imad, technical advisor in Yemen FETB program. Introduction of measles. Negative strand RNA virus. Measles transmitted via droplets from sick person to another person through cough or sneezing, and the symptoms of this disease that started as flu-like symptoms such as runny nose, high grade fever, and bloodshot eye and cough. After that, the skin rash was appear after about 4 days, and before that, tiny white spot inside the mouth. Epidemiology of these measles. Globally, measles is still common in many developing countries, such as in Southeast Asia and Africa. That's killed more than about 100,000 people every year. In 2019, there have been about 440 cases of confirmed cases. In Middle East, the number of cases was about 26,000 in 2019. In our country, in Yemen, because of army conflicts in Yemen since about 2015, many outbreaks was emerged in many governorate of Yemen, such as in Al Bayda Governorate, Damar Governorate, Hanga Governorate, and in Al Hodeidah Governorate, such as this outbreak, which raised the number of cases in 2018 to about 13,000. And in 2019, there was about 9,000 of confirmed cases. And compared with the 2019, we lost decrease of cases in 2019 because of large campaign of measles that conducted in Yemen. The current outbreak on 22 September surveillance officer in Al Marawa district in Al Hudaydah Governorate. Thus, he notified the increase of suspected measles cases in a Dome village and sent their notification through EDU's early warning disease warning system. And this system notified the Yemen Field Yemen training program to send a team in 23 September to investigate on this outbreak. Objectives of this outbreak to confirm the existence of measles outbreak in Al Marawa district and describe the outbreak epidemiologically by time, place, and person, and to recommend control measures. Methods: investigation area and setting. Al Marawa district is one district of Al Hudaydah Governorate and divided to many villages. Ad-Dom village is one of these villages, and its population estimated about 13,000 of people, divided to a group as follow: less than 1 year about 500, and the category from 1 to 5 years about 2,000, and more than 5 about 10,000. Investigation design. We use the descriptive epidemiological methods and the active search from cases from house to house, and lie list was used to collect all the suspected cases from the Dome village. And the lie list contain many variables such as demographical variables and clinical variables and vaccine variables and others. We used WHO, World Health Organization case definition to collect the cases, suspected cases, any person at any age from a Dome village, and suffered from fever and skin rash from Jan to August 2020. And lab investigation, we use lab investigation by ELISA and collect the blood sample. Result: in beginning in these figures, we show the reported measles cases in Al Marawa district and Al Hudaydah Governorate in the time period from Jan August from 2019 and compared to 2020. In this figure show that in 2019 there in this period no any cases registered of measles. In compare with 2020, there is many cases, about 18 cases in this time that indicate the font of this outbreak. In this figure, they show the distribution of measles cases by EB week in Al Marawa district from Jan to August 2020. We show the beginning of cases was in 22 weeks. The index cases was for male children, young children about 9 months, and that die after that. And the peak of the cases was in 26 weeks, and the number of all the cases in this outbreak was about 18 cases. In this figure, the distribution regarding to the of cases regarding the gender, the male represented more than female, about 72%. And in this figure, the distribution of cases according to age group, show the less than 1 years age group represented only 6%. That's represents only 1 case, and the age group from 5 to 15 represented the 5-6%, the more affected age group. Because this age group, why this more affected? More active age group, and that's consume more most of their time outside the house, and get contact with other sick people and get the infection. And this figure, the distribution of measles cases according to symptoms, according to WHO case definition, all the cases must have the fever and skin rash 100%, and other associated symptoms such as runny nose, conjunctivitis, cough, and lymphadenitis. Distribution of measles cases according to the outcome of the disease. We show in this figure most of cases recovered 89%, and 11% of cases represent death. In this figure, distribution of measles cases by reason of unvaccination. We found in this outbreak all the cases that registered was unvaccinated. We tried to collect the reason of unvaccination. We found the most important reasons: a lack of awareness and refuse vaccine. Refuse vaccine represented about 78%. Why refuse the vaccine? Because the fear of the side effect of the vaccine and no trust with health worker in the health facilities in this village. This table shows the case fatality rate and attack rate of measles cases in a Dome village. We divided this to age group. According to age group, the age group from 1 to 5 years represented more attack rate about 3.03, and the overall attack rate of this outbreak about 1.3 for 1,000 in a Dome village, Al Marawa district. And the number of deaths was 2 cases death, less than 1 year 1 cases, and from 1 to 5 years 1 case. So the case fatality rate for the age group less than 1 year was 100%, because only 1 case registered in this age group and die after that. And the overall case fatality rate was 11%. And lab results: a blood sample was collected from 5 cases, and all the samples were positive for the hemoglobin M. In conclusion, measles outbreak was confirmed by laboratory and epidemiological link in a Dome village, Al Marawa district, and the first case, index case, appear in week 22, and that's die after that. The peak of the cases was in week 26. Males were more affected than females, and the most affected age group was 5 to 15 years. All cases were unvaccinated, and the overall attack rate was 1.3 for 1,000, and the case fatality rate about 11%. Recommendation: health promotion about the importance of the immunization, because we found the people in this village not know the importance of vaccination, and them not now the vaccine delivered for all children, and that's present free for all children in Yemen. And promotion health service and center to build trust with patients. Sorry. Early reporting of suspected measles cases. And thank you so much for your attention.
Thank you very much to Dr. Magdi Saif Al-Dari for that presentation. I did see him briefly in the list of attendees. Actually, Dr. Saif is actually here. Let me just promote him to panelist status. Dr. Saif, are you there? Would you like to add anything else to your talk? Thank you for providing that. In any case, it was very eye-opening.
Thank you, bro.
I'd like to invite any questions for Dr. Saif, but just as a general reflection, measles does serve as an old enemy across the world. We obviously see less of it here in the UK, but it's no less disastrous when it does happen. So vigilance, I suppose, and combined with the public health approaches to try and tackle it, as you so rightly described, I think that's the only way we'll ever beat it. Now, we did have a few other speakers on the list for today's talks, but I think because of the chaotic nature of the internet and other problems with attendees being unable to make it, I think we're going to have to draw the conference to a slightly earlier close than planned. So just once again, my sincerest thanks to the organizers and to every one of the speakers who made it today for their valuable contributions. It's been a really eye-opening and illuminating day for me, certainly, and I hope that the rest of you have enjoyed it as well. I think some key takeaway messages from the conference, well, it's about hopefully we're ushering towards an age of global collaboration to try and improve the situation on the ground for all parties concerned. But just hearing firsthand about the various outbreaks regarding dengue, the malaria situation, certainly I've not met many patients from Yemen over the course of my career. So having a greater understanding of the challenges you guys face in your day-to-day work is very illuminating for me. So just as a reminder, for everyone who's joined us today, there will be further conferences planned by the INTERYem Society later on, including a public health conference and a more general infection conference. So this conference is a start to helping with training family medicine in Yemen, and please feel free to join the group forum. Our next steps that we have in mind are to start analyzing family medicine training in Yemen and to work together with colleagues there and in other countries. And perhaps this conference and future ones will serve as a Kickstarter to brainstorm more collaborative efforts in the future. For those of you colleagues who have registered and would like an attendance certificate, we'll send around an online link for a feedback form, and please fill this out and we will send you the attendance certificate for your records. And just as a reminder, if you want to catch any of this again later on YouTube, if you just search the word INTERYem, all of today's content should be available for you to review again. So again, my thanks again to everybody for attending today and to the organizers, in particular Project Director Dr. Mubashir Chowdhury and all of his colleagues, as well as my fellow chair, Dr. Al-Shayer. Thank you very much and all the best.